Department of Pediatric Orthopedics in KGMU, Lucknow. We recently met during my IOA fellowship, which I had gone over there. There is he has more than 16 publications in various journals and more than 62 citations in various other textbook and citations. So he is presently working and in Department of Pediatric Orthopedics in KGMU, and he was the recipient of the prestigious FOSSI Professor Kai Wilkins Traveling Fellowship 2020, which he completed in KMC Manipal and Ahmedabad. And he has also a fellowship in pediatric orthopedics from Wadia Hospital for Children in Mumbai. So we take it is our pleasure to have Dr. Suresh Chand start our session today of pediatric orthopedics, which is definitely a challenging part of the exam. So I hope Sir will be able to enlighten us a lot about this less explored branch and help our students in garnering the requisite skills for the practical exams. And we welcome Dr. Anand Pal sir also. Sir is also pretty keen on the various modalities of treatment of pediatric orthopedics and has been guiding us for a very long time. So welcome, sir, to the meeting. So we'll start with the session right away. I think you can proceed with your presentation.
Thank you so much. And I'm very thankful for this invitation to West Bengal Orthopedic Association. And special thanks to Dr. Rajeev, Raman sir and my friend Abhishek. And I'll start the session, and I hope I'll be able to add some valuable points, because it's always difficult to cover all the topics in a short webinar and it becomes too confusing sometimes. And I'll share my screen. Is it visible now?
Yes, it is visible.
Okay. So yesterday I saw a short, rough presentation for yesterday's session, and it was great. Professor Sudhir is always a great teacher, and I've been his student during my MBBS days in UCMS. So most of the long cases like hip and spine has been covered. I'll try to touch upon the pediatric orthopedic part, and mostly on short case basis. So there is something different we need to give while examining a child. So it's like an art to examine a child. So before going upon to examination in detail, I'll give a brief background what every clinician or every student should know before embarking upon to examining a child and thinking that I'll be able to make a diagnosis. So we need to have a basic idea about the normal growth pattern of the child. Right? What is normal and what is abnormal and what is the range in between. Then only we'll be able to tell what is abnormal and we need to intervene, or we just need to observe. Because more than 50% of the time, it's just normal variation in the growth pattern of the child, and we just observe. Unless we ourselves are sure about the normal growth pattern, we cannot counsel the parents, and it becomes confusing. So we need to know that growth pattern. So in general growth, body weight, height, arm span, etc. should be known. And we should always take a formula or something guide kind of in our OPD itself, that we know what is the weight and appropriate height of the child, right? And ratios are more important, like height for age or weight for height, rather than an absolute weight or absolute height, because again it's a growth pattern which has a wide normal range, right? And we can have plotting on the IAP or WHO growth charts that tells between the percentile, which is the normal, and which is going above or below that normal percentile, right? Below 5 percentile or more than 95 percentile is always bothers and it's a red flag. So we need to have such kind of charts in our OPD. And we need to have basic idea about secondary sexual characters, obviously, to know the growth of the child, right? Then coming to growth of upper limb, we need to have a basic idea what is the normal carrying angle. Generally, it grows more, like, I mean, it's less when the child is younger, and it grows up to 15 to 17 degrees of adulthood carrying angle. The dexterity, most children are bidextrous till the age of 2 to 3 years. If a child is right-handed or left-handed before the 18 months, it's not a good sign. Probably some CP or some neurological issue is there. Elbow range of motion, like in children, we always notice that hyperextension is very normal. So we should not be worried sometimes that the elbow is getting hyperextended, because that is -20 up to -20 of elbow hyperextension is normal. Similarly, if we look at the growth pattern in the lower limbs, there is sagittal alignment and the coronal alignment. Hip neck shaft angle, it is changing over the growing years, like it's 148 degree at birth, and around 158 at birth rather, and 148 at 1 year, and it grows up to 118 or 120 degrees in the adulthood. So this growing pattern, we should be aware to differentiate between normal and abnormal. And obviously, while fixing the fracture neck of femur or any treatment of coxa vara, we need to recreate the age appropriate angle, not that we take the adult values, the implant angles and all. So it's a very basic information, but very useful information. Similarly, knee examination, the varus and valgum, we need to have a fair clarity in our mind what is the normal and what is abnormal. This is famous graph from the one of the common textbook, Tajian, where it has been shown in a graphical form the change of alignment during the childhood. Initially, the legs are in the verum, that is physiological genoverum. Around 18 months to 2 years, it changes from being a verum to valgum. So then it gradually becomes a physiological knock knee. The genovalgum is at the peak around 5 to 7 years. Right? There are various studies which tell a different values, but roughly 5 to 7 years it becomes peak. After 7 years, it falls back to normal genovalgum. So during assessment of child, we should know this background information before embarking upon making a diagnosis or a pathological diagnosis. And this also helps in treating the child and all the counseling and all. This is again same thing. And apart from the sagittal alignment, the femoral anteversion is changing during the growing years. In the child, it's almost 60 degrees of femoral anteversion, which gradually decreases to less than 20 degrees of adult value. So that's again a normal pattern. And in this picture, we can see the child is sitting in W position. So many times it's a very normal finding, and parents come with this complaint. Obviously, we need to rule out other causes, but because of increased femoral anteversion and the resultant increased internal rotation of legs, child finds it more comfortable, and gradually he switches to normal alti-palthi or the cross-legged position. So these are all normal variation. We should know the normal to identify it from abnormal. Then comes the developmental milestones. All the 4 sections of milestones we always get taught during our pediatric postings. So these are valuable during treating the child, and we should have a grossly rough idea about what is the age when the neck holding comes, when is the child is standing with support, without support, and all, no? So that we can have some idea where it is deviating from normal. I'm not going into detail, but that's a rough idea. After this brief background about the pediatric orthopedic approach, now we come to approaching the child in outpatient clinic when we face the child in our OPD, and for that matter in the exam itself, right? So a few efforts are needed while examining the child. We need to provide a child-friendly environment, and we need to establish rapport with the parent as well as children. We might give some toy or something to distract him or maybe engage with us. The room should be well lit and it should be warm for the child, and don't jump into examination or touching the painful part or the pathological part. First have a repo, and then only child will be able to show you more, and the parents will be confident that yes, we can share all our problems with the this doctor, right? Then listen to complaints, and listen all complaints. Sometimes they might be very non-relevant, but the parents are living with child 24 hours. They know what are the issues which sometimes are not visible in the clinic or in the during examination. So we should hear all the complaints, then ask all the history in detail. What was the birth history, developmental history in detail, all these histories, what class the child is in, what is the intelligence, what is his engagement with his peer groups. So all these in the history part, we should cover it, right? Then the examination starts with observation. How is the child engaging with you? How is his behavior, depending on the age of the child. So we need to observe what is his engagement with you and with the surroundings. That will give a fair idea about his development also, and his chief complaint also. Then you have to have a head to toe examination, just like any other examination. And don't forget to inspect the spine. We need to inspect the spine as a whole. We need to focus on the lumbar spine as well as lumbosacral region, any tuft of hair, any dimple or anything, and up also any scoliosis or anything like springle. We should not miss it. It's always better idea to expose the child completely, making it comfortable to the child and parents. But we should not hesitate to expose whole of the back and whole of the child as such. Then comes the gait examination. We should examine the gait. And again, the background of gait, we should all know all the phases of gait, and we should try to observe the gait phase wise and also describe the gait phase wise. That helps practically in day-to-day OPD as well as in the examination. That if you are not able to categorize a gait in like a Trendelenburg gait or short limb gait, sometimes it's all a mixed kind of gait, or there are subtle findings which you cannot place in certain gait classifications. So you can describe the gait phase wise, like the stance phase, what is the position of foot, knee and whole of the trunk. During swing phase, what is the thing there. You just describe the gait: bipedal, unassisted, walking with support, without support, swing phase decreased, or and like. So if you cannot describe the gait, don't stop that you have not examined the gait or you cannot describe it. Just describe what you are saying phase wise, so that examiner gets the information what he needs and you are not stuck at the gate. Right. So like this, this is a slow motion video which we utilize in day-to-day OPD practice. But it gives an idea that we need to examine phase wise. At a one time we cannot examine. We can tell him to walk 3 to 5 times, or maybe repeat again. Look at the foot, look at the knee, look at the ankle. Then only you will be able to collect all the information, make a gait diagnosis according to your thing. Nobody can examine the gait in one go, right? So don't bother, don't panic. Just have 3 to 5 rounds of walking, and you'll be able to make a good observation. And after this basic general examination and history, now you can focus on the area of pathology. Like if the club foot is the case, you can focus on the foot. If it is the TB hip or a neglected EDS, now you can focus on the hip. But that was the basic general examination and basic idea about how to approach a child with examination. Now the hip and the spine has already been covered, and I'll try to focus on pediatric short cases. And mostly the pediatric ortho cases are kept as short cases in the practical examination. There are many in this list, like neurogenic foot deformities, club foot, genu valgum, cubitus varus, non-unilateral condyle with the ulnar nerve palsy or tardinal ulnar nerve palsy, non-union legs, CPT, VIC, and so on. These are the various common cases which are kept in the examination. And it's not possible to cover all them, but I'll try to explain the approach to all the short cases and try to cover one or two short cases in particular. So how should you present a short case in examination? What is the expectation from the examiner and what is the normal trend being followed? So we need to have a balance in between. And there is certain format or a kind of tradition which is being followed all over the institute. So we need to have some basic idea about that. Like if you get a short case in examination, that this is the short case, and the examiner asks, "What is your case or diagnosis?" And the student jumps upon to answer with a cubitus varus or maybe a post-traumatic cubitus varus, and the examiner is not happy with this. Like you have jumped upon the simply a one-word or two-word diagnosis. This is not a very good approach to telling a diagnosis. So a better way to convey your diagnosis would be that this is the patient. I have a 9-year-old boy with left-sided cubitus varus deformity for 12 months duration due to malinoated post-traumatic fracture, most likely supracondylar fracture of humerus without distal neurological deficit. So a sentence has to be framed, including all the information required, nothing extra, nothing less, and it makes examiner happy. A basic idea about case is given. And one more thing about short case is that this is the normal trend. You just need to tell the diagnosis directly. In long cases, you need to tell the introduction of patient, then history, then general examination, then local examination, then at the end you come to diagnosis. However, short cases are the format is like this. Most of the places in the MS and DNB, you need to tell the diagnosis first, but don't give one word or two word diagnosis. Give it in a sentence. So this is I break down the diagnosis part in small sections which are to be included, like age, sex, which side is involved, and in case of upper limb, generally we need to include the dominance also, right? The duration of the problem or the complaint or disease. If you are able to diagnose it, you tell the disease or differential and associating injury or current functional status in a brief, right? So here, if you could include the right 9-year-old boy with right hand dominant with left-sided cubitus varus and so on, that will be additionally more informative, right? But break down all your diagnosis and include all these parts so that examiner gets basic information, and there are few counter questions left for you, and the better or smoothly it goes, right? So, and in short cases, most of the times they are very straightforward. Like if you get a club foot, there is no doubt that it is a club foot, or maybe a cubitus varus. There is no doubt that it is anything else. So it's okay. You don't need to have 2-3 differentials like in a long case, but obviously you should have a thorough background check and history and examination to back your diagnosis. And you don't need to have 2-3 differentials. If you have, you keep it. Otherwise, short cases can be direct, straightforward diagnosis, right? So the next question generally is, why do you say so? Or what are your points in favor of this diagnosis or your this differential? So you need to defend at this stage. Like there was history of fall on outstretched hand. There was history of plaster application for 2 months, and the deformity is non-progressive as per history. And on examination, sir, when I compare to other side, there is negative carrying angle. The supracondylar ridges are thickened. The 3-point bony relationship at elbow is maintained. There is preserved arc of range of motion at elbow with increased hyperextension of elbow and internal rotation of shoulder. There is no distal neurovascular deficit. That's how you defend your diagnosis. This is just an example, and I hope my senior colleague will cover the elbow section later on this series today. This is just an example of cubitus varus. I'm not going into detail, but how you approach to a short case in the examination. Then examiner might ask you, why are you saying that this was a supracondylar fracture and not a flexolateral condyle or maybe intercondylar fracture? Then again, you should have points in favor or in against in saliently in history and examination, right? Then examiner might ask you, how would you like to proceed? And or maybe what's your management? So it's again a mistake generally made by student that he jumps upon to surgery or anything like that. So you don't lose your track. You should say, I'll confirm my diagnosis with the investigations like X-ray or whatever you want. In case of infection and all, you need basic blood workup, right? So you need to confirm. And after that, just have this sentence in your ready that what will you do next? Then again, don't jump to surgery. You have confirmed the diagnosis. Then you will discuss the diagnosis or the disease with the patient or parents, and you'll discuss the options available. Then you give options. There might be 2-3 options. There might be one option only. Then you discuss with the patient and parents, and then you give the option. Then the question goes on to options and all, what kind of surgery, what are the steps and all. No? So this gives a better impression to examiner that you are going for following a proper steps, and you are well read and well trained, and you have a clarity in mind. And in the practice also, this is what we do, and this is how daily workup is done in day-to-day practice, right? So this works in examination also, and please keep this in mind, right? Answer precisely. Don't wander around the question. If you don't know, just skip the question. Tell that I don't know, or maybe sorry, I don't know. I'm not sure about this, right? Don't linger on to that. Just go point by point. Answer precisely. Be confident and calm. That's how the short cases are presented, and the time is also limited in the short cases. Probably 15 to 20 minutes maybe are given per short case, right? With this basic introduction about the short cases format, how short cases are presented and expected to be presented in the examination, I'll try to cover the foot and ankle cases, which are commonly we get in the examination DNB or MS Ortho examination. And the first thing I'll cover is the neurogenic foot deformities. Obviously, you need to have a background information about the anatomy of foot, then only you'll be able to diagnose and treat the foot issues. Right? History and clinical examination. The brief background has been already discussed. In particular to neurogenic foot, you need to look at the complaints. Probably a deformity, abnormal walking, or pain might be the complaint. And don't get confused by previous diagnosis. This is basically in OPD where we see the notes of prior institution, and we get narrow vision with the previous diagnosis. So clinical examination, as I have already said, patient should be adequately exposed with within the comfort of the child, and we should examine the child bare feet, and we should have a habit that we start observing the child once he starts walking in the OPD and our examination room, right? We examine the gait, any gaits, walking aids they are using, and all these section has to be covered: inspection, palpation, movement, and spatial tests. This works in all the short cases, not only in the neurogenic foots, right? Inspect how is the shoes or the walking aids child is using. If the shoe is getting wear and tear from front, probably he is walking with high steppage or a foot drop. If the medial border is there is more wear and tear of more medial border, probably child has planovalgoid and opposite, and so on, right? So the inspection and general awareness of surrounding is also important. Examination in standing position. Examine the lower limb as whole. Don't tunnel vision onto the foot only, right? The alignment of lower limbs, the hip, knee, and the legs, foot, the shoulder and pelvic tilt, alignment of spine, observe the gait from back and front, ask the child to walk on tiptoes, heels, inner border, outer border, squat and stand, hop on each foot, and try to correlate all these findings with some of the probable diagnosis as per the complaint and the age and functional aspect of the patient, right? The heel is examined with a goniometer. You can make a heel bisector. It will tell the basic idea that it is into varus or excessive valgus. Mind you, mild amount of valgus is normal, right? Any thigh or calf muscle wasting, right? When you examine the child from back, like in this picture in the lower down, there are too many toes signs. Probably there is 4-foot adduction or maybe a cavus and adduction. There are too many toes signs, right? In the picture above, we can only see small amount of toes, or just a small view of great toe is visible, right? So that's again a finding which tells you that probably some adduction or 4-foot issue is there. Again, ask the child to stand on tiptoes, right? Valgus getting corrected in tiptoes may be an indication towards the flexibility of that heel valgus, right? And if the arches which were not there before are coming back, then again that tells it is a flexible flat foot. Another test for clearing this out is Jack's toe raise test, where we raise the first toe and the arch comes back. That tells that it is a flexible flat foot. In the rigid flat foot, like in tarsal collision and all, the arch will not come back, which is obviously not a good sign regarding the prognosis of the patient. Coleman block test, the classical test used in cavo-varus foot, right? The patient is asked to keep the foot on the edge of the block, or maybe like a commonly available red brick eat. We use it very commonly because block might not be available there. So if the child keeps feet on the edge and we let the toes go down, the heel varus gets corrected. So that tells that the hind foot deformity is flexible, and our treatment should basically focus on the cavus only, not the varus. This is the anatomical basis for this Coleman block test, right? In the picture on the left side, because the toes are in the same plane, because child wants to keep the feet plantigrade, the heel goes into varus. While putting on the picture on the right side is the Coleman block test. When the heel is on the block and it is plantigrade, the deformity of toes gets unmasked and the heel gets corrected. So this is basically a basis of Coleman block test. The opposite can be obviously true for the planovalgoid feet. The heel valgus gets corrected when you put it on a block or maybe with hands only. So this tells that the hind foot deformity is flexible, and probably a procedure on the midfoot or forefoot will suffice for this patient, right? One of the common tests we do is silver shawl test in the lower limbs, right? The knee is extended. We try to correct the ankle equinus in first, that is first catch, and then we flex the knee and then again try to dorsiflex the knee. If the ankle dorsiflexion, right? If the ankle dorsiflexion is getting improved with the knee flexion, this tells that probably only the gastrocnemius is affected and soleus is not the offending issue. Like this is an anatomical picture showing what is the basis for this test. Because the gastrocnemius comes from above the knee, that's why on flexing the knee, it is getting the equinus is getting corrected, and probably only gastrocnemius is the principal cause of that equinus. This is how you examine the range of motion and deformity. Like in this picture, if you see in first go, you might say there is a lot of equinus at the ankle. However, it is not true. The hind foot is in almost neutral position, probably 5 degrees of dorsiflexion rather. And The forefoot is in the cavus, and which is giving a false idea about the impression of equinus, right? So you can hide the forefoot and midfoot and look at the hindfoot separately. It's like cover uncover test for genu verum or valgum, right? So this is how you examine, right? Obviously, muscle testing has to be thoroughly done. All the groups of muscles are to be examined, and obviously it takes a while to examine this part in the child because he is not able to follow the instructions properly. But you can always observe and try to work around with the toys and all to look at the basic function of all the muscle groups. Look for callosities, ulcers, or any sensation. One of the important tests is Phelps confusion test. This is to diagnose the overactive tibialis anterior. When the child is sitting on the edge of the table and we try to tell him to flex the hip at the knee level, we give a small resistance. And without the child doing it purposely, the ankle gets dorsiflexed. That shows that there is overactive tibialis anterior, and there is probably co-contraction also, and this is very common in cerebral palsy and such neurogenic causes, and this helps in the diagnosis. X-rays, true AP, lateral dorsiflexion, and plantar fasciitis stress views are very common. And in foot deformities, it's very helpful to have a weight-bearing X-rays, like in this equinocaverous foot. The weight-bearing X-ray in the Coleman block test position gives a different picture. The talus and navicular, the orientation or the relation is different in weight-bearing compared to a non-weight-bearing X-ray. This is a picture showing same thing, that the weight-bearing changes the actual position, and weight-bearing X-rays are what matter because we need to improve the gait and function of the child, not the resting position. The X-rays needs to be identified, and it's a good habit to divide foot into 3 segments, and we can describe pathology segment-wise. These are all radiological values we need to be aware, and we can read them from any standard textbook. So now comes the management of foot in the cerebral palsy. If the child presents with equinus only, there is increased plantar flexion at the ankle, and it might be due to spasticity or maybe a contracture of plantar flexus, right? Differentiate between true versus apparent equinus, right? In the ankle area, if you see the angle between the leg and heel or foot, if it is 90 degree but the heel is up, that means it is apparent equinus. Because heel is up, we are getting an impression that it is into equinus. However, the angle is 90 degree. And if we do an tender Achilles surgery in this case, it will be a disaster. So we need to differentiate between true and apparent equinus. Just because heel is up, that doesn't mean that is true equinus. And it is very and more frequently common in CP cases where the jump and all postures are there, which apparent equinus postures are there, which sometimes keep heel off, but the angle is 90 degrees. Differentiate between contracture and spasticity. Always do Silver-Shield test to differentiate between gastrocnemius contracture or a gastrosoleus combined contracture. Treatment general consideration. This is true for CP as a whole. We need to avoid yearly surgeries, which was named as Birthday syndrome by Mercer-Rang. That we get a child with equinus and we do a tail lengthening. Next year we get knee flexed, we do a hamstring surgery. Next year we see a child falling forward, we do a psoas surgery. Then there is a stiff knee, we do rectus surgery. So this is not recommended. And in general, surgeries are to be avoided in CP. And if needed, we need to do SEMLS approach. This is single event multi-level surgery. Do as much as required. SEMLS doesn't mean that you have to do multiple surgery, This is wrong interpretation of that. But yeah, if you require ankle and knee surgeries, and on the both sides and maybe on the upper limbs, you do it in a single sitting. It will be followed by common rehab program, and child will be better, parents will be better, and it will have a less load on the infrastructure as well. So it's a SCMLS approach. Options for spasticity in the leg, especially in CP cases, is casting, ankle foot orthosis, and botulinum vein injection. Right? These work on the spasticity only. They are not answer for the primary cause, which is the brain damage, and we need to counsel that to parents. And they are reversible in their effect, right? After few months or years, the equinus or the spasticity may come back. So it's basically to delay the contracture and delay the need of surgery or the amount of surgery. And again, the silver shield concept and the anatomical basis for equinus contracture helps in the deciding the procedure for equinus. TA lengthening versus gastrosolius recession. These are the anatomical explanation for that, at what level, what structure is there. And this is classical classification of zones like zone 1 and 2 and 3. Zone 3 is practically only the tendo-Achilles region, the whole tendinous part where gastrosoleus both are in a tendon form. The zone 2 is where the gastrocnemius has become tendinous kind of, but the soleus is still muscle. And zone 1 is where both are muscle. So target all zones depending on the examination finding, right? Tail lengthening is done when gastrosoleus is shortened, and gastrosoleus is, rather tail lengthening is done when both are involved, and only gastrosoleus is done when the silver shield test is positive. If you do tail lengthening in every case, it will result in overdue surgery, and it will be a disaster in the form of calcaneus. Mind you, there is no treatment for calcaneus. A small amount of equinus left will be accommodated well rather than a calcaneus. Avoid over lengthening by tail lengthening, especially in diplegics. In hemiplegics, use tail lengthening only if silver shield is negative. And as I mentioned, equinus is better than calcaneus, right? Various methods of gastrosoleus recession, Strayer release, Vulpius release, and Baker's release. And examiners sometimes ask them in the cases as well as on the table viva, and you can go through for the minor differentiates between all these procedures from the standard textbooks. This is TA lengthening, Z lengthening versus the percutaneous 2-cut method or 3-cut method. Post-op rehab is in the form of ankle high groin cast with the ankle in neutral position, and AFO is given after 3 to 6 weeks, and obviously physiotherapy is to be continued. After equinus, we go over to equinovarus foot in cerebral palsy. It is due to muscular imbalance. Inverters are overpowered by over the everters, and gastrocnemius contributes to equinus deformity. And most commonly, we see it in hemiplegics. So again, we can start with casting and bracing to delay the need of definitive surgery. And options of operative depend on the offending agent. Is the tibialis anterior more offending or tibialis posterior? Phelps confusion test, like we discussed, tells the overactivity of the tibialis anterior. Feel for the spasticity of muscles. Sometimes you can correct the equinovarus deformity, and you can feel that the tibialis posterior is tight. If you can also demarcate between if the varus is predominant or the forefoot is more involved, that tells which is more offending, tibialis anterior or tibialis posterior. That's how you do the surgery. If you feel that tibialis posterior is more pathological in this, you can do intramuscular lengthening of tibialis posterior described by Ruda and Frost, or sometimes you can do split tendon transfer. Similarly, you can do similar procedures for tibialis anterior if you feel that it is more offending. Never do a full or total tendon transfer in CP because it will lead to overcorrection and will have iatrogenic deformity. After the equinovarus, then comes the pes valgus. Seen in almost 1/3 of the cases, mostly in the elderly in the sense the teenage group of cerebral palsy, we see pes valgus very commonly, and usually it is present in the diplegics. The cause is again muscular imbalance with chronic loading of the foot in deformed and the imbalanced position. There are spastic peroneal, weak tibialis posterior, and tight gastrosoleus in various combinations. Assess the deformities like a usual foot case, especially look for coexisting equinus or calcaneus deformities. You can correct the valgus and try to dorsiflex the foot, right? You hold the mid and forefoot, otherwise while checking for the equinus, the midfoot will break and you will falsely get an idea that foot is getting dorsiflex, right? You correct the midfoot break and then try to dorsiflex the ankle, then only you'll be able to differentiate. And most of the time they have a tight gastrosoleus, which is missed because of midfoot break. Again, weight bearing x-rays are required. We can try conservative, but in this age, in the teenager cerebral palsy cases, the AFO and the casting may not be long lasting, and bony surgery is generally recommended. Various options theoretically for the pes valgus is Grice, the classical Grice extra-articular arthrodesis, lateral calcaneal column lengthening by Mosca, triple C procedure, arthrodesis or triple arthrodesis. Grice green is extra-articular arthrodesis. It saves the joints, but yes, there are downsides that we need a graft for this, and it might dislodge sometimes, and there might be failures in this, right? The lateral column lengthening, which was pretty popularized by Mosca, the CLO, calcaneal lengthening osteotomy. The lateral column is lengthened so that the medial arch is formed because of tight plantar fascia. So it sometimes works very well, but yes, like any other procedure, it has its own disadvantages or technical difficulties. Triple C is a kind of extra-articular procedure, and calcaneo-cuboid cuneiform osteotomy is done. All three places are targeted, and all are extra-articular osteotomies, and that saves the micromotion at the joints, which is the negative part of a triple arthrodesis, right? So we do a calcaneal osteotomy, correct the varus, heel varus, and we do a cuboid osteotomy, try to correct the lateral column, and we put that graft into medial opening cuneiform osteotomy. So all three parts are targeted in this osteotomy, right? Then another option is arthrodesis using it's kind of a Grice green, but with a implant. There are silicone implants, and the recently Hyprocure screw, titanium screw is available, which is put on the sinus tarsi, and it prevents the valgus of the heel and the planovalgoid posture of foot on walking. And if it works, it works well. Otherwise, there are again very high rates of failure, and the screw is very costly, probably not suitable for our kind of setup. But yeah, theoretically, this is an option. Now, the last option is triple arthrodesis, which is to be done in skeletally mature patients ideally, and not below 12 years theoretically, because the foot size gets decreased because the growth is affected. And in long run, there might be pain. But yeah, there is always a need of triple arthrodesis when everything fails, right? Technical details you can always read through the standard textbooks, and there are various smaller modifications in all the methods of triple arthrodesis, like equinus or equine. What is the predominant deformity? That kind of triple arthrodesis has been defined, but basically all three joints are fused: the subtalar, the calcaneocuboid, and the talonavicular joint. The talonavicular joint is very notorious to go into non-union or the pseudo-arthrosis, and that has to be approached separately sometimes, and a 2-incision technique is sometimes needed to reach the screw. You can use K-wires or screws or whatever makes you comfortable, right? After this, I need to cover the cavus foot, which is again a very common finding. And it's obviously a abnormal elevation of a medial longitudinal arch, and it can be due to various causes, namely cerebral palsy, neurogenic causes like Friedreich ataxia, MMC, Charcot-Marie tooth disease. Polio is not so common, but yeah, theoretically it is a cause. Right. Again, it is due to muscular imbalance, and we need to examine, as I've mentioned. Right. Options for cavus foot are soft tissue surgeries, osteotomies, and arthrodesis. And depending on the cause and muscular imbalance and the age of the child, we need to carve out the options which is best suited for the patient. Right. One of the commonest procedure is plantar fascia release, which can be done like a percutaneous or small incision method, or a proper stainless release with a proper opening and incision. Right. There are certain tendon transfers to counter the muscular imbalance. The peroneal longus to brevis transfer of toe extensors, or very commonly modified Jones procedure. This is brief about Jones procedure. We fuse the interphalangeal joint and transfer the extensor hallucis longus to the metatarsal, so that the cavus or the first metatarsal drop is prevented and the joint is fused. Otherwise, it will create a clot or a toe drop kind of, right? So modified Jones are very commonly used. Various osteotomies has been described, like the Japas osteotomy or the Coles osteotomy for the cavus as well, and they can be utilized depending on the case. This is a flow chart from Benjamin Joseph's book. You can freely go through this, which he has tried to make a flow chart regarding various combinations of pathologies and various combinations of options available. We need to see which is fitting to us, and with a basic background of anatomical and pathological pathoanatomy knowledge, we can easily make out the best available options for the particular case. And it's always helpful to have a flow chart for all the diseases, right? After covering this neurogenic foot part, I'll try to touch upon, because I have some time left now. I'll try to cover the club foot also, which is a very common short case in examination. Club foot, we all know, has a club kind of shape. That's why it is called club foot. The scientific name is congenital talipes equinovarus. And these are the various differentials of a club foot. Anything can present like a club kind of foot. Idiopathic club foot, the classical CTV, arthrogryposis multiplex congenita, MMC, tibial hemimelia, CP, and maybe a polio. Right. These days we don't see it, but yeah, that is a differential. Basic terminologies in club foot, which are asked in examination and obviously useful in day-to-day practice, are various names for club foot, and sometimes we get confused what is what, right? Idiopathic club foot, syndromic, neurogenic, atypical, complex, all are club foot. And so what is the minor differences in these nomenclatures, right? So idiopathic club foot is where there is no known cause of the deformity. Syndromic is where there are associated syndromes, like most commonly an arthrogryposis multiplex congenita or any contractural syndrome. Neurogenic is like having a meningomyelocele or any other spina bifida, anything in the spine. Atypical is where the club foot is probably idiopathic but has atypical features like hyperextended toe, chubby feet, deep undercrease, severe equinus. So it takes hard work to cast the children. That's why they have been labeled as atypical club foot. Complex club foot is any club foot which has been treated by method other than Ponseti method, right? Previously, atypical and complex were being used interchangeably, but recently there have been consensus that atypical is the clubfoot which has atypical features and complexes which have been treated with multiple recipes, and now it is all jumbled up, right? Recurrent or relapse clubfoot are again confusing terms, and we try to use them interchangeably. Any clubfoot which has clubfoot which was corrected before now has deformities back can be called as relapse, and recurrent is sometimes used interchangeably with relapse, as well as a foot which is not getting corrected fully. Also, a difficult clubfoot is also sometimes labeled into recurrent clubfoot, which is going to almost correction, then it is falling back, right? There is always an overlap between definitions, obviously. And then there is untreated or neglected or working age clubfoot, when we don't get any treatment and we get the child in the walking age, walking on the dorsum of the foot with all the callosities and all, right? So such a neglected clubfoot are generally kept in the examination, but we have to have some basic idea about these terminologies, right? In the clubfoot, pathoanatomy is very difficult and hard to go through, but we need to be thorough with the deformities and what are the pathologies involved, bone and joints, muscle and tendons, and capsule and ligaments, all separately. I'm not going into detail because it will be a theoretical class, but when you get a clubfoot examination, you will be asked this, and you need to have a thorough knowledge of pathoanatomy and all the basis for pauncity, difference between pauncity and kite, and what is the kinematic coupling and all, right? So you need to take detailed history of previous treatment and rule out obviously all the differential before labeling it as idiopathic. Routine ankle and foot examination is to be done. Quantify the deformity. If it is a smaller child, maybe an infant or up to 2 years of age, Pirani scoring can be easily applied. In the walking age or in the neglected cases, in a 3 or 4 year old kid, Pirani may not be that applicable. So DiMeglio scoring has to be used, and you should have a basic knowledge about these both of the scorings, and these are being asked in the examination. Right. Treatment of basics of treatment of idiopathic clubfoot. So this is very common question in the exam, that what is your aim in the clubfoot treatment, right? So you'll say that, sir, my aim is to achieve and maintain a painless, plantigrade, supple foot that looks well, functions well, and there is no need of any special kind of shoe, right? We may not be able to fulfill all the aims here, but we try to achieve all and as much as we can have, right? So options are non-operative and operative, depend on the age of the child and your infrastructure and all. Non-operative treatment is Ponseti method and French method. And the operative method is posteromedial soft tissue release, Hony surgeries, and Elijah or just fixator assisted treatments. Ponseti method is essentially a conservative method. French method is similar kind of method, but used with tapes. It is famous in European countries. Nevertheless, Ponseti is gold standard worldwide, and we need to know it in detail. It is done in two phases, the corrective phase and the maintenance phase. Corrective phase includes serial manipulation and casting, followed by a T18otomy. And maintenance phase is done with the foot abduction brace. It can be Dennis Brown splint or Austin Beak foot abduction brace, any brace with a bar in between and around 60 to 70 degrees of abduction. That is foot abduction brace, which is useful in clubfoot. I was describing the atypical clubfoot. Here are the features of atypical clubfoot: the hyperextended toe, chubby, short feet, severe equinus, deep plantar crease, heel is small and squashed, right? So normal methods of Ponseti casting don't work here. So we need to modify a little bit, and we need to raise all the metatarsal. We don't need to abduct. Sometimes early tenotomy and these are required. And in a chubby and swollen foot, sometimes we need to give plaster holiday, that the child is left without plaster for around 6 to 12 weeks, and child goes back into previous form of true club foot, and then we can start Ponseti again. Right? This is just a small brief about the atypical club foot. Now comes the question that can we apply the Ponseti method to a neglected or walking age club foot, which we get in examination? Yes, there are multiple studies now available which prove that Ponseti method works in walking age club foot, and we should always give a trial. Right, PMSTR has limited role these days because on a long-term follow-ups there are overcorrection, painful feet, scarring, and poor function. Right, in the examination, when the examiner asks what is your treatment choice, especially in neglected, like a 5-year-old child with club foot, and if you say Ponseti club foot, some examiner might counter question that will it get corrected fully? So you can say that we'll start with Ponseti casting and we'll try to correct it. After 4 or 5 plaster, we'll have a reassessment, and if it is not going well, we can always go to surgery. A la carte surgery means we'll do release as much required. We'll not do formal PMSTR. We will not release all the tissues. We'll release only things which are required. That will reduce the burden of surgery, and it works well. So the answer is well accepted that you'll always start with stretching cast, and you can always apply 3 to 5 casts before going into surgery. Obviously, there are other options of JES assisted serial correction or Ilijaro assisted serial correction, which all work on the principle of Ponseti principle. Right? They are also options. And there are other treatment strategies like osteotomies, all the dorsolateral wedge osteotomy, Dilwyn Evans osteotomy, Lichblau osteotomy, triple arthrodesis. These are all age dependent, and you can read it from the textbooks. But yeah, the answer could always be well accepted when you say that I'll start with stretching cast, then I might need a la carte surgery, or maybe you can straight away start with Ilijaro or just fixator and you do gradual correction. But the brief and the point to be taken here is we do not do blanket PMSTR in all cases, like this was being done 20 years back, and we have better functional outcomes with a la carte kind of surgery and case-to-case basis of surgery, and serial castings and gradual destruction with fixators, they work well rather than having all kind of osteotomies, right? A common challenge is in the club foot is relapse. Almost 1/3 of cases relapse. That's why the maintenance phase is there. And there is sometimes frank relapse of deformities, or maybe there is sometimes a dynamic supination, right? Non-compliance to brace is the commonest cause, and we have to counsel the parents regarding the non-compliance. That's why every 3 monthly follow-up is required till the 5 years of age. Dynamic supination is when the tibulus anterior is overactive and child is walking, and in the swing phase, the feet is not getting lifted like this, but rather in a supinated form because tibulus anterior is overacting, right? So this is managed by tibialis anterior tendon transfer to the third cuneiform, and this is generally done after the 3 years of age because the tarsal bones get better ossified after 3 years of age, right? So to summarize, in all the foot cases in pediatric age group, the decision is more important than incision. That is, what kind of procedure you are going to have is more time taking and more brainstorming than doing the surgery itself. And we should not tunnel vision and focus on the foot. We need to examine the child as a whole and examine the child completely. Don't hesitate in exposing the back, foot, hip, and all, right? And you need to investigate as required and discuss the diagnosis with the parents. Provide clear, accurate, and reasonable expectations. Don't tell that ये 100% ठीक हो जाएगा या whatever kind of boasting. You need to give real expectation what is to be expected from the surgery. Sometimes parents feel that surgery के बाद everything will be perfect, which is not always a situation, right? In the pediatric foot, we try to preserve the joint motion. That's why osteotomies are avoided, and if required, we do extra-articular osteotomies rather than triple orthodosis or such kind of osteotomy. Thank you so much.
Thank you, Dr. Suresh Chand.
Thank you.
Thank you. Thank you, Dr. Suresh Chand.
Yeah, thank you.
Yeah. So this was a pretty exhaustive and pretty detailed presentation. I'd like to congratulate you on that, because we were having a discussion a few days back that it's such a vast topic, how we will be able to cover it in such a short time. Now, I'd like to invite a few of our seniors and examiners, because this is a topic which is like a little bit for the more experienced people. And if I can request Dr. Bera or Dr. AK Palsa to kindly come online, and we can have a discussion on the pediatric cases a bit, like normally that the students normally see on the exams, or we can have a discussion here as well with you. Dr. Palsa, are you online? Yeah, Dr. Bera. I think Dr. AK Bera sir is online.
Right.
Yeah, right, sir. So sorry to disturb you in the sir, among the OT. We were having a pretty good.
Don't worry. I am prepared for it. Okay.
Right, sir. Right, sir. So we were having a discussion on the various exam cases of pediatric orthopedics. Dr. Suresh Chand has just finished his presentation covering most of the short cases of pediatric orthopedics. Sir, if you can enlighten us about your experience of the various short cases of pediatric orthopedics, and how we, what advice would you give the exam going students that how to approach a short case from your personal experience as examiner as well as a teacher? So. I think the connection is a bit of an issue. Yeah. Sorry. Yeah. So can you unmute yourself so we can then hear you, sir?
Do you hear me?
Yes, sir. Yes, we can hear you.
So every
yes,
alternate, many students will be given in pediatrics ortho either cubitus veras or CTV cases, which Dr. Suresh Chand has already described. So any PGT there who can actively participate, then it will be more fruitful discussion.
Right. So we have been telling them to participate, and I think they are more keen on listening to us, because this is anyhow a very complicated topic. So it is better that we senior people, we try to guide them a little bit with our experience, like in the exams who have given DNB and MS.
So in CTV mostly asked what is the diagnosis that is asked for. So it's first, that is idiopathic, bilateral or unilateral, that you have to tell in a child of with the mentioning the age. Never even old age cases mention neglected case. Never mention it. Neglected. That term is nowadays not acceptable by but most of the authority, because that means blaming someone. Anyway, so that is the common thing, that age should be mentioned with the pyramid score. What is the pyramid score? That should be also told. That you may be wrong in many times, but you always mention, or Dr. Chatterjee told that what is the pyramid score, that should be mentioned. always, if there is secondary, then you must mention the cause, or syndromic or non-syndromic. That you have to mention. So, next question you will ask, you may be asked, why you are calling it congenital? Why you are calling it congenital, and when it can be diagnosed? What are the diagnostic criteria? So that should be answered. Anyone is there? Any PGT? If they respond, that will be more fruitful discussion. Otherwise, it will be like a didactic lecture, which are more of other things, I think. None is responding.
So any postgraduate students over here who are going through our presentation who can just have if they have any doubts or any questions which they would like to pose to Dr. A.K. Bera sir or Dr. Suresh Chand regarding the various aspects of the CTEV and the other pediatric common short cases that we have discussed just now.
None is responding anyway.
Yeah.
So let us continue. So whether X-ray is needed or not for diagnosis, what is the role of the X-ray? That is asked. So by and large, X-ray is not needed for pediatric patient because most of the bones are not well formed. So it's more clinical than, particularly nowadays, very bad. Trans are very early, so all the ossific nucleus that are not radiologically visualized, so very difficult to draw the different axes. So its radiological examination is not needed by and large, except in syndromic cases where you have to find out other causes, whether there is maybe hemimelia or say tibial hemimelia or fibular absence, etc. Third thing is what is the treatment of choice, we know, but how much time, how to manipulate, that's the practical thing asked. So that will be told, asked more. Then you have to tell that before that, one assistant should be who should hold the foot, who should apply the plaster. Those are the common things that missed. So it's the surgeon who should hold the foot in corrected position, because most of the time assistants may not be equipped with the knowledge and skill to hold the foot in a corrected position. And it's the better the assistant will be directed to put the plaster, and then surgeon should mold. How to mold the foot? What is the most important part of the molding? So first, while applying the plaster, you should focus on the heel, so that you put your both the finger, both thumb and index on behind the heel, hold it like this and mold it. Never ever put the finger in the same place. Always rotate it like this and that, so that there is pressure area does not develop inside the plaster. And you have a good plaster. How do you understand from the whether that's a good plaster or not? By molding around the heel. Why is it so important that molding is given so due importance? Because if it is not molded around heel properly, the plaster will slide down, and that will cause not only reduction of the plaster position achieved, but also pressure sore and all these things. Yes?
Yes, sir. So it was like this is about CTEP. I think the various practical points and regarding the treatment, because a lot of the times I think during the exam also they might keep for spotting a child in a Ponseti plaster, and whatever points you have mentioned, that what are the signs of the correct molding of the plaster and what are the various things which we need to see over there. Any comments from Dr. Suresh Chand about it, or like regarding the spotters and that thing, because we will finish off pediatric orthopedics all together, because it's been quite extensive in that over there. Right, sir.
Yeah, I mean, yes. Dr. Bera sir has included all the questions. I think examiners generally do ask these kind of questions only, and he has covered all the things. And I think regarding the attendance of PGs here, no, I mean, I was just trying to share you our experience. These days, PGs, attend the webinars later on YouTube according to their availability, and on the live lectures they are less. So I think they'll listen. Yeah, they listen to it, but I think with their own time and all, they sometimes listen with the speed up on the YouTube. But I'm sure the message will go to them. And Dr. Bera is very, in detail covered all the points there. And I think all the answers they'll be able to, they should be able to give during the practical examination. I think most of the time they falter on the diagnosis part itself. Right. Because they try to answer in 2 word, 3 word, like this is clubfoot or whatever, like this is cubitus varus. They need to give all details in a long sentence, but in a one sentence, so that examiner के पास पूछने के लिए कम रहे, so that he goes forward to next question. So like rightly said that clubfoot, bilateral, unilateral, idiopathic, congenital kind of we need to make into parts, and it has to be a sentence, and all the questions regarding the technique of Ponseti, cast applications, and all these, I think they are valid questions, and every student should know. And most of the time, if they have assisted or they have observed in the plaster room, they will be able to answer it.
And what is the trend now regarding, like we have since both of us have, like when we gave our exam, that time also the polio related deformities had become quite less in the present scenario. So is it a practice now that the examiners tell, suppose if there is a polio case, they will be mentioning directly that no, this is a polio case, now you can proceed, because our students have seen so less polio cases in the recent time, that it is like imperative and that we inform them about the polio cases? Or what is the trend that you follow as a examiner or a teacher? Like, what's your view about this?
Polio nowadays, you are rightly told that nowadays much less it's found in the adult polio much more than the children, quite obviously. So, but the deformity, the neurological deficit is there or not, neuromuscular deficit, that should be mentioned. Regarding polio, I think patients are, nowadays surgeons are, examiners are much more forgiving, because that's a lesser number of cases are seen even by the faculties nowadays. But never with the examination of spine dysraphism or myelomeningocele hidden or occult, that should be always noted for.
Okay, sir. Right, sir. And just one more small input from my own experience as a DNB, during my DNB practical exam. I had a case of facial dysplasia in one of the short cases, and I think the examiner had put an 8 plate, or what he had done was basically a facial modulation that we do nowadays, and
growth modulation.
Yeah, growth
modulation,
which they did, and they had basically mentioned that do you think that I operated this is this the right modality of treatment? So we'll have an opinion from Dr. Suresh Chand and you, so both.
Yes, excuse me. Yes.
The examiner had actually asked me that whether this is the right treatment for a fascial dysplasia, and that.
Okay.
So I had answered in the negative that since this is a case of epiphyseal dysplasia, so it is not very wise to put a growth modulating plate and like not do a fascial modulation and that over there. So what's your view on this thing? This is just a very personal experience. So
right. So basically, where there is deformity in a growing child, you can put some growth modulation, therefore 8 plate, etc. Okay, or whatever thing nowadays, 8 plates are more involved. But in epiphyseal dysplasia, what the examiner is rightly told, or you have also rightly told, you do not know what will be the ultimate deformity. Whatever appears today, that may be altered next day. So before the substantial period of growth, we should not embark on this growth modulation like in fascial injury. Say fascial injury with varus or valgus, there you can put it earlier. Okay. So in my take is that as epiphyseal dysplasia is a thing of unpredictable, unknown etiology where growth disturbance pattern is not also well established. Exactly. Therefore, to interfere early, it will be a bit less wise. Okay, that's I think. Okay.
So I think
any feedback from Dr. Suresh Chand, please.
Yeah,
I think the first thing to understand here is because the physis is not normal in these all the dysplasias. No, so they are called a sick physis. Right, the amount of deformity correction as expected from a normal physis after application of 8 plate will not be there. However, having that in mind, we can always try depending on the deformity already there and the age left there and our counseling. Like around 15-20 deformities there, and we are giving a shot that it might work. Maybe we can try. But yes, we need to understand that this is sick physis and 1 degree per month or roughly estimate of correction we give in normal physis will not be there. Probably half or maybe less than that.
Our next speaker, Dr. Anirban Chatterjee, sir, who is also a pediatric orthopedic surgeon. He is one of our teachers and one of our guiding lights in Kolkata. He has also joined now in our discussion. Welcome, sir. Are you online, sir?
Welcome. Let us hear from him. Okay. Thank you.
Yes, sir. Hello. Yes, sir. So thank you, sir.
Thank you, Dr. Saha. Okay.
Thank you, sir.
I am also, though I am in the OT, I am always.
Thank you, sir.
We are
honored, sir, that you came. So we will be waiting for your talk on the.
My talk is very simple. I have prepared today of my so many schedules. Today is World Environment Day. There is some tournament, all these things. I had prepared just short time. It's more just open. Anyway, you may, Soham, I have sent you the video. You may cut it short. Okay, I think Dr. Pal is there. He will be more on academic side. So you may cut it short. Okay, my presentation. Don't worry. Okay, Soham, I am giving the liberty. Okay, thank you very much.
Okay. Welcome, Soham. Yeah. I think Dr. Anirban Chatterjee sir is here. So welcome, sir. So I think you can, it is.
Okay, can you hear me? Am I audible?
Yes, sir. Yes, sir. And so we would also like to thank. Welcome, sir.
Shall I start sharing my screen?
Yes, sir. Yes, sir. Kindly do, sir.
Okay, so the brief for me was to go over the X-rays that is there in the MS Ortho and the DNB Ortho exam. So this is a table which is often a cause of concern to a lot of students, as to what is to be said, how it is to be said, and what all goes about it. So I've just put together a couple of slides on this. So we'll go through this. So in a nutshell, we'll go through what are the contents in that table, what are the requirements, what are the expectations from the candidates, and go over some case examples. Now, when you look at the table contents, it's essentially a radiology table. So candidates will be getting either some X-rays or some CT scans and maybe some MRI scans. Now, what is the requirement from this table? Usually time allotted is about 10 minutes. At least 2 X-rays are usually discussed per candidate, preferably 1 X-ray and maybe a CT or an MRI depending on the center and what is available. And usually 1 trauma and 1 disease is the way it is distributed, so that assessment about the candidate's knowledge about each of these parts of the curriculum can be obtained. So what is expected from the candidate? They must be aware that what is being tested. So what is being tested is the ability to read an image, be it an X-ray, a CT, or an MRI. Similarly, we also are taking the ability to identify normal radiological anatomy, the ability to identify a pathology, the ability to interpret the findings. So essentially, and because there are no clinical details provided, so this is sort of like representing how a radiologist would look at an image and come up with certain interpretations and then go on to further discussion. So we are essentially checking the cognitive domain of the candidate, the analytical ability, and the rational interpretation of findings. So what do we expect from the candidate? They must identify and read that particular X-ray, identify the main pathology, propose a differential diagnosis or a definitive diagnosis if they are confident enough from the X-ray itself. Certain pearls, the X-ray is essentially a starting point for the discussion on the Viva OC, and further discussion essentially depends on the response from the candidate. So let us go to some case examples. This is an example of a trauma scenario. So one must go in a systematic manner, identify the parts that are visible, start from the periphery and come to proceed to the center. This is called the centripetal type of approach. Identify the patient details on the side if it is visible within the image. If not, then you say it is not visible. Identify if it is of a mature or immature skeletal. Again, if age details are not visible. If it is, then you identify whatever is present. Yet, one must not forget the soft tissues. What is the soft tissues which are evident from there? Look at the main pathology. Is it a fracture? Is it a dislocation? Or is it a fracture dislocation? If it is a fracture, then one needs to describe the site where it is happening within the bone, whether it's metaphyseal, diaphyseal, juxta-articular, extra-articular. What is the fracture pattern? Is it a short oblique, or long oblique, or a spiral fracture, or is it a simple transverse fracture? And if you know the classification, then it is expected that you tell us the classification. So coming back to this case example, look at what is expected from this X-ray. I would expect the candidate to say that this is a plain X-ray of the femur, including the hip and the knee and a part of the leg, that it belongs to an immature skeletal. The age and patient details on the side is not specified in this particular image. The fracture is in the mid shaft or the diaphyseal fracture of the shaft of the femur. There is then that the fracture is a displaced fracture, it is angulated and it's an oblique fracture, and there is a soft tissue swelling around the region of the fracture. Now, one must not take a lot of time to do this presentation of this part, and that is where the candidate needs to practice saying all of this. A lot of time we find candidates they saying, "Sir, this is a plain sciagram of the leg or the femur or the thigh showing upper part, a little bit of the acetabulum, part of the iliac crest, and a little bit of..." So by the time you come to the actual main pathology, you have already spent up some amount of time. Please remember that you have only about 10 minutes and you need to discuss at least 2 X-rays. So we want you to be prompt, specific, do not waste time in unnecessary words, but clearly come to the point that yes, this is an X-ray of the femur, including the hip, knee, and part of the leg. It is immature skeletal. It is showing a fracture in the shaft of the femur, mid shaft, and that it is displaced, angulated, and oblique. Further to this, the questions will come. Common questions would be looking at the X-ray. Okay, this is a fracture shaft femur in a child. How do you think was the mechanism of injury in this child? Suppose I give you, since the age is not specified, suppose the examiner says that, okay, I'll tell you that this age is less than 1 year. Now, in a less than 1 year child, what are the possible mechanisms? What is a common mechanism? Looking at the fracture, is it a high velocity injury or is it a low velocity injury? Then what are simple treatment options that you know about? So if you say that, sir, I would like to do a spica cast or a traction, if so, what traction? Spica cast, would you do it immediately? So some relevant questions related to the treatment would be expected from the candidate. So essentially, this is the starting point for the Viva OC, and it will proceed a little further. And then you would move on to maybe some another X-ray. So the diagnosis here is a pediatric shaft femur fracture, and discussion will go according to that. Let us go to another example. Here is a case of again a trauma. So again, what is expected from this X-ray? There is a plain X-ray of the ankle, including a part of the leg and foot. That it belongs to a mature skeleton is evident. The patient details are mentioned. The side, however, is not mentioned here. There is fractures both in the medial lateral and the posterior malleoli of the ankle. The particular fracture types are in the medial malleolus is a transverse. In the lateral malleolus, it's a short oblique, just at the lesion of the syndesmosis or just intrasyndesmotic, and then there is an oblique or a shear fracture of the posterior malleolus with a posterior subluxation of talus along with the rest of the foot. And there is soft tissue swelling around the region of the fracture. So our diagnosis would be an adult trimalleolar ankle fracture with posterior subluxation of the talus. Now the examiner can ask you, okay, do you know of a classification? What are the classification systems? So the Log-Hansen type of classification or the Weber classification would be expected. What is the common mechanism? What about the soft tissue conditions? So then a rational question pattern would follow and some questions about the treatment. Now let us look at a case of a disease. Again, as in a case with trauma, you would follow a systematic pattern, identify the parts that are visible. Again, start from the periphery, proceed to the center, identify the patient details, and identify again if it is a mature or immature skeleton. Then you would come to the soft tissues if there are relevant. Coming to the main pathology, is it unilateral? Is it bilateral? Is it similar on both the sides? If it is approximate, if it is appearing there is the same disease, can it be possible that the two diseases are in the diseases are in two different phases or stages of the disease? So that needs to be mentioned. Looking at the joint, is the joint visible or not? What is the pattern of destruction? Is it a uniform pattern of destruction or is there a sectoral type of a destruction? And then the classification if that. So for the candidate, they must describe what the disease is doing to the host bone and describe what the host bone is doing for the disease. So if you look at an X-ray in this sort of a way, you will likely not miss out the salient features, and therefore you will be able to come to at least a differential diagnosis and then proceed further. Now I'll come to another type of an X-ray, which is very commonly given to candidates, which is an X-ray of a bone tumor or a lytic lesion in the bone. So commonest way the question comes is either you read the X-ray or what is your diagnosis looking at this X-ray. Now this is a matter of concern. How do you describe this particular type of a lesion and what are the differential diagnosis or diagnosis? Can you come to a logical? candidates would often give us varied answers. It's like, is this a simple bone cyst? Or somebody would say, no, this is a osteoblastoma, or is a non-ossifying fibroma. But all of them may be correct or incorrect. But what is the order in which the differential diagnosis is placed also becomes important. So what is expected from a candidate when you are given an X-ray like this? Read the X-ray, identify the elements of the tumor, come to a differential diagnosis or a diagnosis that's absolutely evident. So how do you read the X-ray of a bone tumor? You must look at the type of lesion. Is it a lytic lesion? Is it a sclerotic lesion? Or is it a mixed lesion? Look at the site, meaning which bone of the body is it affecting, and then look at the location within the bone, whether it is epiphyseal, metaphyseal, or diaphyseal. And then again, within the bone, is it in the center of the bone, or is it to one side? So it is centric or eccentric. Again, look at the number of lesions. In one X-ray, you might find only a single lesion. So that's a solitary lesion. In opposed to certain cases, you might find there are multiple lesions within the X-ray which is given to you. So then it's a multiple lesion. Look at the shape of that tumor. Is it uniform or is it not uniform? Is it round or oval shape, or is it not? Is it expansile or non-expansile? Meaning, what is the tumor doing to the host bone? Is it expanding the cortex or is it not? Sometimes it may balloon out. So maybe so huge that it is actually blown out one part of the tumor, which is common seen in aggressive giant cell tumors or in some aneurysmal bone cysts. So that is then whether it is contained or not. But again, a similar way of saying, meaning whether the cortex has been eroded, breached, broken, like that. So when a tumor starts from inside and starts to erode on the bone, sometimes the radiologist will report it as end osteal scalloping. So it is scalloping of the tumor. Whereas sometimes it may have, there is a cortical breach. They may say that essentially it is saying that there is a pathological fracture. So which is evident in this X-ray. So like that. Then look at the margins. Is it smooth or is it variegated? Is it well defined or not well defined? Look at the zone of transition, meaning is it wide zone of transition or narrow zone of transition? So what is the zone of transition is a very common question which is asked. So the zone of transition is essentially the point of differentiation between the tumor or the abnormal bone and the normal bone. So if you can see that you can clearly demarcate the zone of differentiation between the abnormal bone and the normal bone, then it is a narrow zone, meaning as if you could draw a line with a pencil around that edge of the bone. That is a narrow zone of transition. Whereas a wide zone means you cannot make out there is a abnormal bone there, and gradually it mixes up with normal bone. So the zone of transition from abnormal to normal is a wide zone, which is commonly seen with aggressive lesions. Okay. And then again, we must not forget the soft tissues. Look at the soft periosteal reaction or soft tissue swelling if it is present and evident from that X-ray. Then we have to come to an important part of the bone tumor X-ray, which is the matrix. Now, what does matrix mean? Matrix is the mineralization which happens within the lesion. And different patterns exist, and they provide a clue to the histological origin of the lesion. And therefore, you can, in certain cases, come to a very specific diagnosis on the basis of the X-ray alone. So the matrix can be uniform, it can be homogeneous or heterogeneous. It can have a ground glass type of appearance, as in a case like this, where it's like a fibrous dysplasia, or you can have a cumulus cloud type of an appearance, as in a osteoid matrix of osteosarcoma, or you can have popcorn arc ring or speckled calcifications. That indicates that there is a cartilaginous origin of the tumor, as you can see in, say, a chondrosarcoma or, say, an enchondroma like this. When you look at the periosteal reaction, whether is it solid, thick, or wavy, essentially it means it's a benign lesion. If it is laminated or lamellated or onion skin type of appearance, or rarely where there is a sunburst type of appearance, then it represents a more aggressive lesion or an aggressive tumor. So these are certain pictures. Here you can see there is a solid element, there is where there are lamellated ones, then spiculated, and finally a sunburst. And you can get the classical Codman's triangle. Essentially, it looks at a aggressive lesion, which is most likely to be a malignancy. What is this periosteal reaction telling us? That means the host bone the tumor is growing at such a rapid rate that the host bone is not getting the time to consolidate and go through all the phases of new bone formation. It is getting interrupted at times. Again, a little bit of new bone is forming. Again, another layer is forming. So that's why you get, as it goes more and more aggressive, you get more of this elevation of the periosteal reaction. So now let us decode some of the jargon. Examiners sometimes like to hear these words, and sometimes these are mentioned in your radiology reports as well. So sometimes it may be mentioned that is a geographic lesion. So what is a geographic lesion? It essentially means that it is well defined or well marginated. You can identify the margins clearly. And essentially, it refers to the zone of transition. So if you can get a geographic lesion, that means the zone of transition is narrow. A non-geographic lesion essentially is therefore a poorly differentiated, defined. It can also be used a term as a permeative lesion or a moth-eaten appearance, which is very classical of, say, a multiple myeloma. It's multiple lesions, moth-eaten appearance, and it refers to a narrow zone of transition. Then what is happening to the cortex? It starts off in the medullary zone. Is it endosteal, meaning just inside the is it periosteal or parosteal, cortical, entirely within the cortex? And there can be endosteal scalloping. Then whether it is concentric or eccentric. So these are some of the terms which you may often come across through a radiologist report, and you may get confused. So these are terminology which one should be aware of, and sometimes these are expected, but you must know which is what, where you can interchangeably use one. So to summarize, let us look at this X-ray. Have a systematic approach. Look at the age first, because on the basis of age itself, you can cut down your differential diagnosis to a lot of different ones. Is it mature or immature? Look at the number. Is it solitary, polyostotic, multiple lesions? Within the bone, where is it? Meaning, where is it in the epiphysis, metaphysis, or diaphysis, whether it's centric or eccentric? Look at which bone is affected. And that can give you a clue, because certain tumors occur like we know that giant cell tumors are juxtaarticular, occur very commonly around the knee and around the distal radius, as is the case here. So that itself can give you a clue as to what is the likely diagnosis. What is the matrix? Is it a ground glass appearance? It is a honeycombed appearance. There is a speckle calcification. That will give you an idea. Look at the edge. What is the cortical destruction? Is a scalloping there? And then what is the zone of transition? The periosteal reaction. So finally, you can come to a conclusion that this is most likely a giant cell tumor of the bone. Now, one must also look at certain questions one can ask oneself from a candidate's perspective. Looking at this X-ray, what type of skeleton it is? It is mature, immature. What bone is affected? Distal radius. Site within the bone, epiphysis, metaphysis, diaphysis, centric, eccentric. What about the margins? Circumscribed, diffuse. What is the lesion doing to the host bone? It is essentially a lytic lesion. What is the host doing to the lesion? There is some periosteal reaction, or is there some zone of transition present? So if you answer these questions to yourself, you will not miss out on what is happening, and accordingly you will be able to completely identify the lesion and then come to a differential diagnosis. Now, when it comes to benign lytic lesions in bone, this is a common mnemonic we fall back on, which is phlegmomashic or fog machines, whichever way you can remember it. If you go through each one of these, then it means it could be a fibrous dysplasia, enchondroma, eosinophilic granuloma, giant cell tumor, non-ossifying fibroma, osteoblastoma or osteoid osteoma, metastasis and or multiple myeloma, aneurysmal bone cyst, solitary or simple bone cyst, brown tumor of hyperparathyroidism, often multiple, infection in any phase can mimic a tumor, so therefore it is included in the list. And finally, a chondroblastoma or chondromyxoid fibroma. So on the basis of this, you can now add further qualifiers. Depending on whether it is solitary or not, you can have particular ones. Whether there is pain or there is periostitis, certain things are there. On the if it is a simple bone cyst, aneurysmal bone cysts are usually slightly eccentric, tends to expand in the cortex. Simple bone cysts, early stage, don't expand. Later on, they do expand. So like this, you can come to a differential diagnosis on the basis of certain criteria. So if it is less than 30, you can make a differential diagnosis list that it could be any of these. Again, then depending on the features. If it is epiphyseal per se, then you can talk only about these particular. Here I've included a geode. Geode is essentially a subarticular cyst, which is commonly seen on X-rays or on MRI in a degenerative condition. So there might be a degenerative osteoarthritis, which gives you a similar situation. Similarly, you can make a differential diagnosis list of malignant lesions. So here you have Ewing's, osteosarcoma, fibrosarcoma, METs, etc. Similarly, again, you can create a list of sclerotic lesions alone. And then you can know that these are the conditions which you would be expected or which can be shown, as is shown here, a case of Paget's or a case of sickle cell disease. Now, certain pitfalls are something which needs to be remembered. Certain lesions will mimic the aggressiveness. And here I'm showing you a case of a benign periosteitis, which is seen in infants. This is Caffey's disease. Now, this can be mistaken as a Ewing sarcoma, and but this is entirely a benign process seen in infants, and it is self-limiting. Therefore, does not require any investigation. So, certain pitfalls are things which are there, which one must be aware of before jumping to the conclusion. However, saying that, as an examiner, if a candidate mentions in the differential diagnosis that this is actually a Ewing sarcoma or a small cell sarcoma, because Ewing's is known to involve the small bones, I'm sure he will not be penalized, because he's interpreting this X-ray without the clinical picture, and therefore one should not penalize a candidate if he says as the differential diagnosis that, or even as the first diagnosis, that this is a Ewing sarcoma. Then we come to a few special X-rays, meaning X-rays where there is a sinogram done or there is an arthrogram done, and or a scanogram. So here you can see this is a 10-year-old girl where there is a sinogram has been done, and you can see the dye being injected, and you can see the dye going all the way inside into the cavity. So here questions may be asked as to how it is done, what is the reason for doing that, so that you can identify the sinus, and then a few questions about the type of the infection, that it is chronic osteomyelitis, whether a sequestration is seen, not seen, and then go on about the further management of the patient. So these are some of the ways we can go through with different X-rays and essentially come to a complete conclusion about what the X-ray is showing and what is expected of the candidate. Now, is there more time? Can I go over some case examples, or should I stop? Abhishek?
Yes, sir. Hello.
Hello.
So can you hear me? Yeah.
Yeah, I can hear you.
Yeah, so we were so engrossed in listening to your lecture that we just wanted you to continue and that over there. Anyhow, so just a short note on what are the common mistakes which the students make in the exam, which you have seen as a DNB teacher and an examiner yourself. So.
Okay, so like I said, let me go through simple. Let's take. Okay, so let us take this X-ray per se. Okay, here you can see that this is an X-ray of the spine. You can see the AP and the lateral views included. It's a 77-year-old lady. The patient details are mentioned. What is the essential point that is seen? We often find that the candidate wastes a lot of time in trying to read, all this. This is the right side labeled so and so number of 77 years, female, X-ray taken in 2015. This is waste the time when we actually want the candidate to say, okay, fine, this is all not so relevant. It's good that you identify and make sure that this is of the patient you are discussing. But on the radiology table, it is not so important. In the long case or the short case, if you have already examined the patient and you are given an X-ray, then you need to confirm that this is of the X-ray of the same patient. But on the radiology table, since time is of concern, constraint, we don't want you to waste time there. We want you to come straight away saying that, yeah, there are, as you can see, there are multiple level wedge compression fractures and a possible, not very clear on this X-ray, but yes, there is a anterolisthesis, at least a grade 2 anterolisthesis.
Exactly.
So we would want the candidate to come to the pathology as quickly as possible. If there are more than 2 pathologies, as is evident here, that there is a spondylolisthesis as well as multiple wedge compression fractures. And then the general look of the entire skeleton. So the discussion is likely to go towards osteoporosis because there are 2 different conditions. Spondylolisthesis, lysis is not so evident on this X-ray. So one can maybe ask, would you like further imaging, or how can this be better portrayed? Simply put, if you look, there are a lot of gas shadows here. The simplest answer is, sir, I could repeat the X-ray with proper bowel preparation. This X-ray appears to have been done without bowel preparation. Okay. Because examiners always expect, a common mistake is people would say immediately, okay, I'll do an MRI. But before the MRI, I would want, why not repeat the X-ray with good bowel preparation and also do a flexion extension view or a standing lateral view. So that will give you a more functional analysis of the condition before you jump to an MRI. Now, jumping to an MRI before seeing the X-ray can also give problems because part of the listhesis can reduce on the supine MRI, and you may get a less amount of listhesis reported on the MRI as compared to what is there on the X-ray. So those are certain pitfalls which are there. Accordingly, then you can proceed. Right? Are there any questions in the chat box?
I think our next speaker, Dr. G.G Kar sir, has also joined in. Sir, would you like to make any comments or any inputs to this?
So, Abhishek, hello.
Yes.
Just I heard.
Yes, sir.
Yes, Dr. Chatterjee has rightly told that not just to jump to MRI, it's the approach, the X-ray, what is evident, what are the possibilities, why you are thinking like that, and what are the problems. 2-3 problems are there. There will listhesis, there is fracture, there is osteoporosis. So with these things, what are the possibilities that you would never jump to next investigation? What is evident in the X-ray, you tell it, and the minute details that's you have to explain, including the your inability to focus on that only, and you will like to have the approach in which the student is telling. That's more important. That we judge very much. Okay, so that is a clinical radiological and no investigation is foolproof. So that attitude should be reflected in the while reading the X-ray. Okay, that's the only feedback. Thank you.
Absolutely.
Carry on.
Right. And so we are very thankful to Anirban Chatterjee sir for getting ready on such a short notice and being ready with the presentation and helping us and as well as the students in going through their own this thing preparation regarding the X-rays and that. Thank you, sir. So it was really nice listening to. I was so engrossed that I could not till you called. It was really engrossing, sir. Thank you, sir.
I just, if there are any questions in the chat box or any other queries, then I can answer that, and then I'll stop sharing my screen.
Right, sir. Any questions from the students? I think we have got some students now online with us. They can ask their questions, and I think, or they can inbox us here.
Yeah, they can type in the chat box, and we can have a
look over there. Any questions about the X-rays? Because this is something which, with the onset of the OSCEs and that in the DNB exam, I think this section has become equally important as the long case and the short cases, sir. That's what I think.
Yeah, actually, if you see, X-rays are included in the OSCE as well, especially for those appearing for the DNB exam. And on an OSCE, not just one or two, multiple questions can be asked on one particular X-ray. So in an OSCE station, there might be the first OSCE would be just to show the picture, and 1A would be to identify the salient points of the lesion which is shown. Say for this X-ray which is being shown, there is a lesion in the proximal phalanx of the middle finger. Okay, it's slightly expanding the cortex. You can see that there is possibly a pathological fracture. It has eroded the cortex. There is endosteal scalloping on one side. It is a well circumscribed lesion. And if you look at the matrix, there is some calcification inside. So again, if we go back to the algorithm now, this is a less than 30-year-old individual, immature skeleton, hand, which is a common place, endosteal scalloping and chondroid type of matrix. So most probable diagnosis would be an enchondroma. Okay. Now in this case, if the candidate says that this is a GCT, that's not correct, right? If the candidate says this could be an aneurysmal bone cyst, I could still agree as a differential diagnosis. Simple bone cyst, I could still agree, but lower down. Okay. But if he says this could be a fibrous dysplasia, then no, it does not match the age. It does not match the commonest site for that particular tumor. Say there is a fibrous dysplasia is more commonly seen around the proximal femur. If he says that this could be an eosinophilic granuloma, again, it is not so common. Eosinophilic granuloma is seen, okay, in a younger child, yes, but not in the hands and fingers, right? So if you go by that algorithm, meaning what is the age of the patient, what is the site within the skeleton, site within the bone, what is the matrix, what is the zone of transition, all those points you can actually narrow it down from those 13, 14 conditions which is there in the mnemonic. Okay. Right. So similarly, if we go to say another X-ray, this is a similar one again in the hand or finger. Here you can see again a similar sort of lesion, but with a small fracture in the proximal phalanx. But here you can see make out the difference between the previous X-ray and this X-ray. That this one had a chondroid type of a matrix, but here the matrix is not so chondroid. So this is more likely here if the candidate says that this is juxta-articular and this is most likely to be a giant cell tumor, then I would be accepting that. Okay. Look at this X-ray, bone tumor. Okay, this is in the mid shaft, a fracture through a bone cyst. Here, yes, we can take the differential diagnosis of a solitary bone cyst. Aneurysmal bone cyst, unlikely in the diaphysis. Infection, yes, we would keep in mind because infection is a mimicker, right? But eosinophilic granuloma, all those other things, fibrous dysplasia in the middle of the shaft, very rare. Okay, so once you know the mnemonic and the algorithm, then if you give us only 2 or 3 or maximum 4 differential diagnoses, it is more than sufficient. Take this example, proximal femur, a lytic lesion in the proximal femur. Okay, here if you say simple bone cyst, aneurysmal bone cyst, fibrous dysplasia, yeah, agreed. These are the possibilities, right? Here, simple bone cyst with a path fracture, proximal humerus, Simple bone cyst is most likely the diagnosis. Of course, as a differential infection, etc., can be considered, and visible bone cyst can be considered. As opposed to this, again, in the proximal humerus, where it's expansile the cortex and there is a small path fracture. Or a condition like this. Here you can see very specifically that the tumor has involved the epiphysis and it has gone on to the metaphysis. Because the epiphysis is involved, it's most likely to be a chondroblastoma rather than anything else. Very specific. Chondroblastoma is a tumor which starts in the epiphysis. So an epiphyseal location of the tumor will most likely be a chondroblastoma, as opposed to this condition. So you've got a completely almost destroyed base of the metatarsal in an adult skeleton, right? So this could be a giant cell tumor which could have broken through, or it could be a more aggressive or malignant lesion as well, right? Or could be a metastasis, because we are looking at an adult skeleton. Now here, if somebody says this could be an aneurysmal bone cyst or a simple bone cyst, then obviously you are wrong, right? So that is what common mistakes happen, and that's what the examiner.
This is regarding the OSCE, sir. This will be like all the X-rays that you showed. This can be like a pretty good point over there, so that
yeah. In the OSCE like, also it is asked like that only. So they will put up this X-ray as one, and then there will be question about identify where it is happening, what are the attributes of the features which you see on the X-ray. So that will be station 1A. Okay, after 4 seconds, you will get station 1B. So next will be what are the likely differential diagnosis, 1, 2, 3, 4 points about it. Okay.
So we would like to listen to you over and over. We have been listening to you for this thing, but I think the G.G Kar sir is already online and he is pinging me continuously about it. So thank you so much, sir, for your presentation. It was really a pleasure to listen to you. So if you can stop sharing it. G.G Kar sir, are you online, sir? Yeah, so we will be having Dr. G.G Kar sir now online in a short time, who will start the presentation. Welcome, sir. So we were waiting for you for a very long time. So can you unmute yourself, sir?
Can you hear me?
Yes, sir. Please start.
Yeah. And the screen is also visible?
Yes, sir. So the screen is visible, so you can go for a presentation mode. I think then it will be entire thing will be visible. Yes.
So after the X-rays, we come to the reading of the MRI.
Yes.
Now, reading is a relative term because we can all read these, but we do not understand the language. So reading is not equal to understanding. But to understand the MRI, the first step is not to look at the MRI. It may sound preposterous, but the fact is that if you do not assess the patient the old way, like your listen, think, re-listen, general like in local examination, like your look, feel, move, measure, special tests, and then see the X-ray if relevant. If we do not perform all those seemingly boring things, seemingly old things, we do not understand the MRI because without the clinical knowledge, even if the frame is in front of me, my mind may not read what is in the frame. And why the PGTs try to understand, why the PGT should try to understand, because this question arises because there are no MRI table in practical examination, at least for nowadays, and they can read the printed report. So what's the point? It was a 23 years old advice, MRI for the uninitiated by Dr. W.P. But that is magic. If you therefore don't try to understand, just believe in the report. Because everyone, lawyers, patients, and family, but hopefully not you, will believe in the report rather than clinical findings, lab tests, or experience. For example, this boy, this is a 21-year-old boy, came to me with the problem in the lateral side of the knee joint, right knee joint. And from the X-ray, we can see that the lateral joint space is more than the medial joint space. Obviously, in this 20 years of age, we do not think about diminished joint cartilage space over here. Actually, this is increased space over there. And you can see in consecutive cuts, the whole of the body of the lateral meniscus. How do you know that this is a lateral? Because this is a convex condyle, and fibula is looking here. So in 1, 2, 3, 4, 5 consecutive cuts, the lateral meniscus was visible. And in a cross section also, you can see the whole of the black thing is the lateral meniscus. The report was partial tear of anterior cruciate ligament, annular tear of medial meniscus, and effusion. So I wrote them that the patient has no history of injury. Without any history of injury, there should not be any anterior cruciate ligament tear. And the problem is on the lateral side. And I also pointed out that there are so many cuts visible in the whole body of the meniscus. Then there was a correction from their aspect that yes, there was a discovered lateral meniscus body in 3 consecutive sagittal cuts. Of course, there was some thickening of the ACL insertion, but no definitive tear. Another patient, 35 years, RTA patient. From the MRI itself, it is very obvious that the PCL attachment from the tibia has avulsed. What was the report? Grade 2 medial meniscus tear, anterior cruciate ligament to grade 1, etc., etc. Again, there was a feedback from me, and now they have come up with this avulsion of the tibial attachment. Sometimes report may forget that there are 2 cruciate ligaments in the knee joint at all. There are no comments about anterior cruciate, posterior cruciate ligament in this report. No mention of those cruciates. So I again wrote them that yes, there is, we should mention that this is status of the ACL and PCL, and that gentle reminder worked. There was mentioning of this posterior cruciate ligament mildly thickened and intrasubstance edema tear of the anterior cruciate ligament. What we find in the arthroscopy, and in those frames were there, you can see that there is partial tear of the ACL here. And obviously in arthroscopy, there was oblique tear here and partial tear of the ACL substance. Another case, you see, even with uninitiated eyes, we can discern that there is a fracture over here, separating this condyle from that one. But the report didn't mention anything about the fracture. This was in after one just around week. The patient went to another surgeon. He prescribed another MRI, and that came out with the fracture involving the intercondylar region of this. Similar situation in these 2 pictures. We can see that there is a avulsion of the PCL attachment, missed in report, horizontal tear and PHMM, AHLM, and traumatic hemarthrosis. So our mission is try to interpret on our own. There are a wide range of use of MRI, from trauma to articular cartilage, from tumors to infections to stress fractures and avascularity, spine, pelvis, and limbs. And we look for tendons and muscles, bones, ligaments, joints. So it's very difficult to delineate everything in one session. We'll just touch the basics. Why do we prescribe an MRI when there are no clue, even after thorough clinical examination and other investigations? Sometimes you have some idea, but need to know better. And there are other times when you are certain about the diagnosis, For example, there is a definite history of a trauma followed by knee instability episodes leading to frequent giveaway, and you find by your clinical test that the ACL is gone. Still, you have to do an MRI. Why? Because you need more information whether the other structures are involved, whether there is bone edema, etc. And sometimes you need documentation. The background you already know, the PGTs already know that. The full name is nuclear magnetic resonance imaging. It implies that it has got to do something with nucleus of the atom, magnetism, that is actually electromagnetism, the resonance phenomenon, and the imaging out of all these three. The overall process is that patient is placed in a strong magnetic field, so that's a spinning protons, which are actually electrically charged things, become like small magnets, and they orientate themselves along the magnetic field. And then a radio frequency pulse is sent into the body to reorientate themselves. And then when the radio frequency pulse is turned off, these oriented protons, they come back to their original state and release some energy. That energy is picked up by sensors and converted into an image. That is the basic. Now, remember Drishyam, where Ajay Devgan or Mohanlal wanted to see us what we didn't see. Here is an example that the same picture, the knee joint can look totally different, unlike an X-ray where there are shades of gray only. Here, there is stark difference between these two just because of the sequence difference. For example, in these, for an uninitiated, this may look like a horizontal cleavage through the anterior horn of the medial meniscus. But if you go through all the other frames, you can see that these are motion artifacts. This is also a motion artifact, not a tear. This is the photography of MRI. We all read this for many, many years, decades, that what looks in which way in different sequences, T1, T2, STIR, and T1 plus contrast. This is a slide to be remembered, but gradually when we look at the pictures more and more, this will come automatically in our minds. The reading process is that which cut is you are looking at. Is it a coronal, axial, or a sagittal cut? Where you are coming from anterior to posterior, from proximal to distal, or medial to lateral. If it is a coronal cut, then you are coming from anterior to posterior usually. If it is an axial cut, you come to proximal to distal. And if it is a sagittal cut, usually the technicians frame, they provide you the frame from medial to lateral. What structures you are focusing on depends on which joint or which part of the limb or spine you are looking at. Then comes the question, is the structure normal? Normal in normal location, normal in orientation, and normal in look, that is the consistency. Any MRI sequence can tell you all these anatomical features, but if you look at the physiology, you'll have to have specific MRI sequences for specific kind of contents. Example, this is a T1, fat is bright, blood is also bright. Here, CSF is darker than the disc. This is the disc. CSF looks darker than the disc. This is the specialty of T1, simple T1. Now, if we get a T2, the fluid becomes immediately brighter. So there is good contrast between this and the fluid, right? This is almost equal or darker to the disc, and this is much brighter than the disc because this is T2, and the fat is still bright. Now we can have darker fat by STIR. There are several sequences in different modes, different weightages that we can suppress the fat. Sometimes it helps, sometimes it does not. We'll see. Take the example of a 49-year-old female who fell from bike, and this is the one part. This is the non-fat saturated image. The moment the fat is saturated, that is, the fat is made darker, this area becomes contrast in brightness because this area is not doesn't have fluid, doesn't have fat, but there are hematoses. Blood has accumulated. Here, the fat suppression helps to get contrast. But to look for contrast, for example, Shah Rukh Khan is having a contrasted dress to have him outlined from the rest of the extras. In fibrocartilage, not suppressing the fat is helpful. Why? Because you see, this is a fat suppressed and this is not fat suppressed. Here, the fat in the medullary cancellous area helps to distinguish between the bone and the fibrocartilage. Here, the distinction is less because it is fat suppressed. So sometimes not suppressing the fat is helpful. Here also, in the intercondylar area, you can find the black PCL and the black cartilage, the fibrocartilage, that is the meniscus. Part of meniscus is in the intercondylar notch, which is abnormal, which is not in normal location. The same thing happens in other areas. Here you see the black man stands out because the periphery is bright. Mostly, we do not need contrast in musculoskeletal MRI except few situations where there is a tumor or a tumorous lesion. You can see this. These are without contrast, T1, visible but without contrast. Now with contrast, this one, and in T2 with contrast, you can jump upon the lesions jump upon you. The lesion which was very subtle here becomes very prominent because of the contrast. And you can see this also. Bone marrow edema or bone marrow contusion or the marrow edema. This one is a typical area for the PGTs of ACL injury. This is an indirect sign of ACL injury. Posteromedial area of the tibia gets shot, just like your hotspot in a cricket. When the ball touches the bat or the pad or the body, that area becomes a hotspot. Because of this tucker between these two and this, that area becomes a hotspot. Only in T2 fat cell. There are marrow problems, proliferation of the marrow. This is abnormally black. This is darker than even the IV disc. These are the discs. The marrow is even darker. So this is a case of leukemia. In STIR, marrow is slightly more bright. Yeah, marrow is slightly more bright than this. And it has become replaced. This is a known case of, the patient was a known case of CA prostate. And these are the deposits. Deposits, marrow is replaced by those tissues. And in another case, not in this case, after chemotherapy, the marrow can be wholly divided, depletion of the marrow. Coming to the tendons, tendons are almost uniformly black in almost all the sequences. So this is a black tendon over here. These are the black tendons over there. If something is there, in contrast, you can have that in a fat set tissue because the fluid becomes whitish. Here, this is a typical arthrogram. You can see the black tendon in contrast with the contrast fluid. There are different kinds of tendon troubles, not going into that. Normal tenosynovitis, but there are partial tears, thickening, thinning out and split, and then complete disruption. For example, this is a thickened one here, and the fluid is prominent around the tendon, that is a tenosynovitis. Next, there is a split tendon, split. Here, you can see the tibial posterior split. The patient was of a flat foot patient. There was tibial posterior tendon dysfunction. This is a disrupted tendon. Obviously, you can see that there is a disruption. Clinically, you can diagnose, but for documentation and to know the condition of the tendons this way and that way, you need an MRI. Dislocation of the tendon. Here, you cannot find any tendon. This is a normal kind of tendon, black over here. The empty bicipital groove, and this flattened tendon is the biceps over here. There can be calcium deposits. Calcium looks white in X-rays. Usually they look black in tissue. This is a recent example. I saw this boy today only. Not boy, the man today only. He had injured knee and somebody prescribed an MRI because clinically there was tenderness. The patient cannot bear weight, but there was no significant features in the X-rays. And now you can see that MRI can even diagnose, detect fractures. Leg pain in young child. Something is there. Looks like a mixed kind of response there. And the moment there is a MRI, you can delineate that there is a nidus over here and the surrounding area goes there and it brights up. So not only the osteodyostema, but the reactive bone marrow edema is also very evident here. So this kind of, I'm shortening it here because I have to catch a train and be ready for this. I'm very sorry.
Yes, sir. Right, sir. Right, sir. So you already updated me. Thank you, sir, for coming online and enlightening us. You're always a joy to listen to. We have listened to your lectures over the year, and we'll just give like a minute or two to our students if they have any questions to ask or anyone wants to give any input and that over there. So anyone wants to, like, they can inbox us or just drop a message in the chat or directly chat, like have a
message in the chat box and I can try.
Sure.
Even on the plane, I can try.
Right, sir. Right, sir. So thank you, sir. Thank you, sir, for the enlightening lecture. It was a pleasure listening to you, sir.
Goodbye for now.
Right. Dr. A.K. Pal, sir, will be giving the next lecture on elbow. I think sir is already online. He's also waiting for the last 50 minutes. So sorry for the delay, sir. So kindly unmute yourself. So if you can unmute yourself, sir.
Yes. Good evening. Good evening, everybody. So I think I'm supposed to show the shoulder examination as also the elbow examination.
Right, sir.
Okay. So first of all, I'm starting the shoulder examination. There are common complaints like pain, stiffness, instability, rarely swelling and wasting. Now, I'm not going into detail because I just want to highlight that mainly those the points which are very important for the examination. That is okay. So there are some complaints of sudden development of symptoms, like it may be due to trauma, it may be due to overuse, or there is no cause like acute rotator cuff tendonitis, or it may be due to gradual complaints like the without trauma, there is chronic instability, acute joint AC joint irritation, following overuse. And if there is no cause is found, there is a chronic rotator cuff tendonitis which is related with some age or adhesive capsulitis. Now, age predilection. Sometimes if you can divide the cases of shoulder patients into two, is very distinct. The young patients, like 20-40 years, that may present with some chronic instability of the shoulder, AC joint injury of the pectoralis major tear, whereas middle to old age may be related with the rotator cuff tendonitis, rotator cuff tear, the subacromial bursitis, bicipital tendonitis, and capsulitis. Now, we have to concentrate on the area of the symptoms. Which part of the area is mostly complained of, like the anterior shoulder region, is a or the anterior lateral posterior region, or the diffuse or over the top. So if the anterior shoulder region, it may be due to bicipital tendonitis, or there is some pectoralis muscle tear, which is in the younger age. Anterior and lateral or posterior, which is all the areas involved with rotator cuff tendonitis or the tear or shoulder instability, whereas diffuse symptoms may be due to adhesive capsulitis. Over the top, that may be due to as AC joint disease. Now, type of the symptoms, it may be sharp pain, it may be dull ache, or it may be dull ache at the wrist or the sharp pain on the sudden movements, or it may be stiffness without pain, or sometimes there is some crepitations. So every causes may have some related with some diseases, as I have noticed about. So students easily follow this, whether it is a sharp pain on the shoulder motions, maybe due to rotator cuff tear, or stiffness without pain. That is painless stiffness. Most probably it is adhesive capsulitis. Whereas in this stiffness, it's painful stiffness may be due to associated with some arthritis like that. Now, causes of the painful shoulder may be divided into two. It may be stiff shoulder, it may be non-stiff shoulder. Stiff shoulder, it may be due to synovitis, cartilage lesions, rotator cuff lesions, frozen shoulder, or the infection. Whereas the non-stiff lesion, non-stiff problems, that is, there's some pain without stiffness. It may be due to superior labral anteroposterior lesion, slap lesion, but it's a bicipital tendinitis, or this acromioclavicular osteoarthritis. Now, how to examine? You have to see the look. Most important is the symmetry. Shoulder, both the shoulder and the shoulder girdle, it maintains the symmetry and the special contour and some elevation and the depressions. So we have to see the attitude. So there's a basic examination of orthopedics is the same in all joints, like the attitude deformity. There are 3 points: attitude deformity, swelling, wasting, and the skin. In attitude, basically, they have to see the external or whether the patient has come with external or internal rotational attitude. There's supports by the other hand, as you can see in this picture, or there is some deformity, that is the loss of rounded contour or the abduction, the length discrepancy. There is swelling, and there's a effusion at the, that is the deltopectoral groove or posterior deltoid or the axilla. And wasting, you have to see the where the maximum muscle bulk is there, like the deltoid, trapezius, and the supraspinatus, as also the skin abnormality. Now, from the front, we have to see from the center, they have to see the elevation of the sternocleidomastoid, clavicle, deltopectoral groove. In this, this is on the deltopectoral groove, the AC joint, this is its joint, and the rounded contour of the shoulder. From the side, we have to see the AC joint, this rounded contour of the shoulder. There is deltopectoral groove as also scapular position. Whereas from the back, we have to see the position of the head, upper border of the shoulder, that is trapezius, whether it is irregular or not, spine of the scapula with muscle bulk above or below to it, to have the bulk of the supraspinatus, intraspinatus, and also the scapular position from the midline. Symmetry of the soft and the hard tissues, including the relative position of 3 bony points, are also compared with the other side. So in this manner, you can see these are supraspinatus, intraspinatus muscle vesting. As you can see here, you see there is some significant restriction, significant flattening of the deltoid, and also there is significant vesting all around the shoulder joints. If you compensate, this is the normal muscles, as you can see here. From the side, yes, you can see here, this is the same thing. This is the posterior triangle, this is the sternocleidomastoid, clavicle, this round contour of the shoulder, where the rounded contour is completely lost over there. As you can see here, it is completely flat. So there is a obliteration of the deltopectoral groove. So that is maybe a case of shoulder dislocation. Whereas in this case, there is some groove is all visible. You can see some groove is just below the subcutaneous prominence of the acromion, and that may be the possibility of the paralytic case, because see the muscles are completely vested. So there are some natural and elevation and depression. So what are the natural elevation? Like the rounded contour of the shoulder, clavicle, spine of the scapula, and the wave of the neck, that is trapezius. Natural depression is the supraclavicular fossa. This is the one, and the axilla as also the deltopectoral groove. This one. So these are the symmetry of both the elevation and the depression should be compared on the other side. Now, abnormality of the contour, it may be flattened, or it may be prominent or rounded. It may be flattened due to vesting, as I have shown you, dislocation or the paralysis, whereas the prominent may be due to effusion or the subdeltoid bursitis. So there are several causes. These are the questions usually asked in the examination: necrosis or flatness of the shoulder. What are the differential diagnosis of the swelling of the clavicle? Like this, I'm not going into detail. Now see the drooping of the shoulder. How do I examine the drooping of the shoulder? This is the simple way by which we can easily examine the drooping. So that there's either imaginary vertical line is drawn from the center of the occiput to the natal cleft, and another horizontal line is drawn from the uppermost point of the shoulder. So ideally, what will happen? So this horizontal line, which is at right angle to this vertical line, should touch both the shoulder. But if one shoulder is below that line, that side is not at a some level, that means side is there is drooping of that side. And similarly, this is the sulcus sign. This is same. It can easily compared with the other side. Now there are drooping of the shoulder. There are several differential diagnosis of the drooping of the shoulder, like paralytic condition, dislocation, fracture neck of the scapula, fracture proximal humerus, or there's some disease atrophy, and that can be easily differentiated in this on this point. There's deformity, loss of rounded contours, sulcus sign. You see the sulcus sign is positive only in the paralytic condition. Fullness of the deltopectoral groove. In direct tenderness is positive in the proximal humerus. Whereas in the fracture neck of the scapula, direct tenderness is not possible. Only the indirect tenderness. That is push. If you push the arm from the elbow, holding the elbow and push the arm towards the center, that is the indirect tenderness on axial pressure. That will be possible to diagnose the fracture of the neck of the scapula. Now the palpation is you have to stand on the back of the patient, palpate in a continuous manner from the suprasternal notch to the deep Swiss spine, from the center to center. So, and first we have to examine the temperature, then the tenderness, as you can see, and the other joints, then irregularity, thickening, and the broadening, then palpate the structural symmetry on both the sides. Technique of eliciting tenderness is the anterior aspect of the shoulder joint. We have to see here just below the coracoid process. This is the area where we have to examine the tenderness for the shoulder joint. Just below the coracoid process. Coracoid process is easily understand how you examine. This is the methods how you is asked in the examination how to identify the coracoid process. So the coracoid process is situated just at the junction of the medial 2/3 and lateral 1/3 of the clavicle. So we have to identify that point. From that point, just go below. There is a loss of resistance. If you go further below, the first bony point, if you go further below along this junction, it is the coracoid process. And if you see for the tenderness on the below the coracoid process, this is the anterior aspect of the shoulder joint. Similarly, posterior aspect of the shoulder joint is palpated with just below the angle of the acromion. Now again, this is a method how to how to identify the angle of the acromion, because this is the most important point for measurement. This is a measurement for the upper point or for the arm length. So we have to start from the back. We have to start from the spine of the scapula. So we have to go further lateral, from medial to lateral side. Once the spine of the scapula rotates anteriorly, so that is the angle. So that is how the spine meets with the acromion process. So that is the angle of the scapula. And if you go just below it, that is the posterior point where the shoulder joint becomes exposed to the posterior side. So there are anterior shoulder and also the posterior joint tenderness. Now, differential diagnosis of subacromion tenderness. So there may be anterolateral tenderness, it may be lateral tenderness, it may be posterior tenderness, or maybe posterolateral tenderness. So that depending on that, it may be the greater tuberosity fracture, or if the tendon is all over there, or that may be acute rotator cuff tear. So structures to be palpated from this sternoclavicular joint, following by the clavicle, acromioclavicular joint, then spine of the scapula, the DT spine, then this acromion. From the acromion, you have to understand the greater tuberosity. How to identify the greater tuberosity? This is also another another method. So just you have to you put your thumb just below the acromion, and if we extend the shoulder, and then if you can easily identify the bony point which just comes underneath the acromion during the extension of the shoulder, that is the greater tuberosity. And now it is become confirmed by rotating the shoulder, holding the elbow, holding the part of the distal part of the humerus. So that will rotate with the rotation of the shoulder. So that is basically the greater tuberosity. So that is the method of identifying the greater tuberosity, because it is very important to identify it. We have to have a diagnosis of greater tuberosity, any fracture, or there is some bicipital groove which is just medial to that point. If there is some bicipital tendinitis, the tenderness will be elicited just on the medial to that bony point of the greater tuberosity. So another is the lateral inferior angle and the vertebral angle of the scapula. You can be easily identified, and the corresponding spinous process can be easily identified. Now the three bony point relationship, that is the coracoid process, acromion end of the clavicle, and the greater tuberosity. That these are the three bony points, like the same three bony points of the elbow, that has to be examined for the diagnosis of any dislocation of the acromion process, or any fracture dislocation of the lateral end of the clavicle, or there are some bony dysplasia, or there is a greater tuberosity fracture. Now, angle of the acromion, it will start from the inferior border of the scapula. As I have already told, I'm not going to detail. Tenderness, you have to examine just lateral to the coracoid process, below anterior rim of the acromion, and over the bicipital groove. As how it can be identified, I've just described. For bicipital groove, we have to identify the greater tuberosity, and we have to go just medial to the greater tuberosity, in keeping the elbow, keeping the shoulder extended. And if we just press posteriorly, that is the area where the bicipital groove is there. So is there any tenderness that will be diagnostic of bicipital tendinitis or pectoralis muscle tear? The acromioclavicular joint is easily understood. It is easily palpable because it is superficial. To go along this clavicle, there is a loss of resistance, and once there is loss of, that is the acromioclavicular joint. There are some special tests I'm going to show. Now, how to difference between the shoulder effusion and subdeltoid bursitis, that may be asked. So, like swelling extend beyond the anterior and posterior margin of the deltoid and along the long axis of the biceps, that is the shoulder effusion, that can be easily identified with the help of the range of motion, which is all the range of motion should be painful and restricted. But in the subdeltoid bursitis, there will be diffuse fullness beneath the deltoid muscles only, but the other joints, as it is just outside the joint is involved. So the other flexion extension movement is painless because other movements which strokes the deltoid are very painful. So this is the way you can easily identify. See, this is the diffuse swelling, as you can see here. This is the subdeltoid bursitis. Subdeltoid bursitis, and how it shows can aspirate it, and see this is the effusion. This is the shoulder effusion. As you can see, it is going going beyond the anterior border of the deltoid, obliterating this deltopectoral groove, as you can compare on the other side. So this is not a subdeltoid bursitis, this is a effusion. Now shoulder motions. There will be mild limitation of the shoulder abduction, or the limitation of the abduction and the flexion, or it may be all motions limited except especially the abduction and external rotation, or there will be pain on flexion and full extension. So these are the four categories of the shoulder motion restriction. It is mild limitation of the abduction, like the acute rotator cuff tendinitis. Limitation of the abduction and flexion is the chronic rotator cuff tendinitis. Is all motions limited, especially the abduction and external rotation is the adhesive capsulitis. Whereas pain on flexion from full extension, it is a bicipital tendinitis. Pain with limitation of the external external extension and the external rotation, basically it is due to pectoralis muscle tear. Whereas full range of motion, it is basically it is a chronic instability. আচ্ছা 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 তোমার নাম্বারটা দিয়েছি না নাম্বারটা আমি পাঠাচ্ছি তোমাকে নাম্বারটা পাঠাচ্ছি আচ্ছা নাম্বারটা পাঠাচ্ছি How to examine the shoulder rotations. So limitation of the external rotation can be done either the shoulder by the side of the body or at right angle to the side of the body. So if the limb is kept by the side of the body, so it may be difficult. It may be difficult to examine the internal rotation, but whether the limb is at the right angle, so it is very easy to take. So so shoulder should be examined in abducted position. That is most important. So that is so shoulder rotation should be examined in abducted position. This is most important. Okay. So limitation of the external rotation in 90 degree is ideal to examine the rotation of the shoulder. Now, the painful off motions, where there is a full range of motion is there, but pain is in the mid range of the abduction is there. That is between the 120 to 180 degree. That is the most important for diagnosis of this. So that is the painful off motions. Now there are differential diagnosis of painful and painful off syndrome. There is either chronic supraspinal tendinitis, subacromial bursitis, or there is some incomplete rupture of the supraspinal tendon. There's a crack fracture, greater tuberosity, and also there crack fracture, greater tuberosity of the humerus. There are increased arm length and the decreased arm length. That increased arm length may be due to the fracture of the scapula or subglenoid dislocation, whereas decreased arm length basically is due to the displaced fracture of neck of the humerus, displaced fracture of the shaft of the humerus, or subcoracoid dislocation. So there are differential diagnosis of increased vertical circumference of the axilla. It may be due to some any dislocation of the shoulder, fracture upper end of the humerus, fracture neck of the scapula. Now the basics of any test, we have to take the consent of the patient. We have to explain the procedure to the patient, position of the patient and the examiner, and the procedure without hurting the patient. Sometimes they repeat the test, and lastly the inferences and the interpretation. Now there are different tests of the shoulder, like specific muscles for the rotator cuff tear, And for the impingement, that is basically the rotator cuff disease, whereas inference, it may be pain, it may be to weakness or on instability or the both. So, so there are 4 categories of the test, like specific muscle test, impingement test, instability of the laxity, and the labral tear test, and the AC joint test. Now, for the supraspinal test, we can do the full can test or the empty can test or the drop arm test. Infraspinal test, that's the external rotation. Its function is external rotation that can be examined by keeping the arm by the side of the body, and the Pattis test. Subscapularis is by the belly press and the lip top test. And also the biceps is the elbow flexion and the supination. Now, assessment of the rotator cuff, that is, we have to ask the patient to elevate the shoulder at 90 degree and 30 degree supination or pronation. The supraspinal is the full can and the drop arm test. So ask the patient to elevate the arm against the resistance. If the patient is complaining of pain, that is basically the supraspinal is a Job's test. See, this is the empty can test. This is the full can test, whether there is a thumb is up, and this is a drop arm test. Ask the patient just to elevate the arm up to the 80 degree, or arm is elevated up to 90 degree passively. Now ask the patient to lower the upper limb smoothly and gradually. But if there is supraspinal tear, so the arm cannot be reduced, cannot be lowered down, and that will just drops at a glance. Now, Pattis test, infraspinal is basically the external rotation. So now hold the shoulder at a 90 degree. Once it is that is externally rotated, it is against external rotation is tested against resistance. It is known as the Pattis test. And inference is there is no pain, resist external rotation is the normal, whereas the pain but resist is the tendonitis, whereas unable to resist with gradual lowering of the forearm, that is a horn blower position. Like the patient will hold in this manner as during the blowing of the horn. So if the external rotation is ruptured, the patient is unable to hold, and there's a gradual lowering of the hand from this elevated position because of the loss of power of the external rotator. That is the horn blower test. And similar, the external rotation can be tested by keeping the arm by the side of the body. So this is for the infraspinal test. Now, subscapularis basically it is the belly press or the lip top test. If the internal rotation range of motion is significantly there, there is a sufficient amount of range of motion is there. So in that case, ask the patient to do that. So because it requires significant internal rotation. Now ask the patient to elevate the arm away from the trunk against the resistance. So if it is possible, then it is normal. Otherwise, if the patient is complaining of pain, that is partial tear, is unable to do that, that is a complete tear. Whereas if the internal rotation range of motion is not significantly there, then only the belly press test is done. So in that case, they ask the patient to press the belly against the supinated arm, supinated palm. But remember that the arm should be just in front of the axis of the trunk. So initiation of the treatment, initiation of the stress, and ask the patient to press the belly against resistance. So if it is not there, it is not possible. Otherwise, if it presses it, but at the same time, the arm is going backwards, that is the belly press test is positive. Now, test of the biceps tendon, speed test is a 90-degree abduction against the resistance. Ergations is the sitting position. That is the sitting position, and the arm by the side of the body. Hold the patient in fully pronated forearm. Ask the patient to extend the supinate against the resistance. That is the Ergations test. And then see the speed test is a simple test for the biceps. Ask the patient to elevate the shoulder at 90 degree, and ask the patient to elevate the limb against the resistance. So this is the resist elevation pressing over the arm. That is the speed test. And the Ergations test I just told, keeping the arm by the side of the body. That is resist the supination of the pronated forearm. That is the Ergations test. And now the impingement, basically the position of the impingement is basically the forward flexion and the internal rotation. If we forward flexion internally rotated, then the whole of the humeral, anterior part of the humeral head comes in close contact with the anterior glenoid, and that leads to impingement. So that is the impingement position, the forward flexion, internal rotation. So in this position, there are 3 tests is described. There's a near test, there's a painful arc, there is Hawkins test and the Okun's test. Basically, it helps on, there's a forward flexion and internal rotation, it is done. The Hawking kinetic test is basically a simple test. You can easily done. This is a forward flexion, internal rotation. Raise the limb in this manner of the examiner's hand, and just adapt and forward flexion and that the internal rotation, and that will lead to a pain, complaint of pain. Nearest test is just internally rotate and elevate or forward flexion. It should be done, and that will patient will complain of pain. And the Occam test is basically ask the patient to keep the hand on the opposite shoulder and to elevate the shoulder, and the examiner will resist the elevation of the elbow. That is the Occam's test. Now, instability. What is the unstable position? Unstable position of the shoulder is the abduction. At the same time, if there is externally rotated. So abduction, external rotation is basically is the position of the instability. So it is if this abduction, internal rotation is with some provocation can be done, that is additional, leads to some instability. So abduction, external rotation is the position of the instability for the anterior instability, and the adduction, internal rotation is the position of instability, the posterior side. So along with that, we can do some provocation. Just push from the suppose for the anterior, we have to push from the posterior side. For the posterior instability, we have to push from the anterior side. So this is the basic things. So there are some apprehension tests, relocation test, anterior drawer, load and shift test, posterior apprehension and jaw test, and the posterior drawer. So see the simple thing. The abduction, external rotation is done. And now if the provocation is done from the anterior side, this is the anterior provocation. So this apprehension test, basically it is with provocation. At the same time, if we push from the back, that is the relocation test. So abduction, external rotation is the common factor. If we push from the front, that is apprehension test. If we push from the back, it is a relocation test. This is the same thing is being done. Abduction, external rotation, pushing from the front, and also see this is the fulcrum test. So abduction, external rotation, and there's a push and pull. Just like it's saying this drag test, basically it is known as the fulcrum test. This is basically the anterior shoulder instability. and see the provocation test. So this is just push from the back for provoking the anterior dislocation. And same thing that if you push from the front for this dislocation, it is to examine the laxity. There is a load and shift test. So how the load is given, the whole of the body weight or the weight of the upper limb is given at the load. Along with that, we have to push it from the back. So that is so load is taken. It is dragged anteriorly. At the same time, we have to push it so that whether we have to see whether it is coming out and whether it is going in. So that is the same thing. It is like the Burlow's test of the DDH. Now, posterior apprehension test, it is a forward flexion and internal rotation, because I have told it is the position of the posterior instability. So in that case, if we push backwards and if you see we palpate on the posterior side, so in that case, if we can easily palpate that something is going backwards. So the test is just hold the scapula, hold the limb in this manner. There is adduction, there is forward flexion, internal rotation, and push the limb posteriorly. We have to feel that something is going back. So labral tear, this is basically this labral tear is the biceps load test 1 and 2, new pain provocation test, and active compression of Bryan's test. So basically, it is adjunct to the injuries. Then, like the dislocations, anterior inferior labrum, in biceps tear, there is superior posterior or posterior superior labrum. So how it can be done? So there is simple things. This labral test is abduction, external rotation. Along with that, ask the patient to flex it. So abduction, external rotation is same as the instability. Along with that, if you ask the patient to flex the elbow, so in that case, we are utilizing the function of the biceps, which is attached to the superior labrum. So basically, this is the labrum test, is the biceps load test. So there is abduction, external rotation, along with biceps contraction. So in that case, if the patient is complaining of pain, this is a biceps load test. I think this is a single test is sufficient enough for remembering. And another test is the biceps O'Brien test. So this is for 90-degree forward flexion. Ask the patient to pronate the forearm. So and ask the patient to elevate against the resistance. If the patient is complaining of pain just below the acromion, this is due to the labral tear. If above the acromion, it is due to acromioclavicular joint. Now, if the same test is, if it is repeated, keeping the elbow in supinated position and the pain is relieved, that it is confirmatory for diagnosis of the labral tear. So this is the O'Brien's test basically. So it's O'Brien test basically it can diagnose the labral tear as also the AC tear. I think these are the two tests, the biceps load test and the O'Brien's test is sufficient enough for diagnosis of this labral tear. Now AC joint is causes a direct trauma. It may be due to the involved in the direct trauma. It's a chronic overuse stress, exercise like the bench press, deep or the push up, localized tenderness, painful arc motion, and the special test. So this is the AC joint is a cross arm adduction test. You can see here, arm flexed to 90 degree, arm adducted to more than 45 degree, elbow is forcefully approximated to opposite shoulder. And the positive test is pain in the AC joint. Same AC and watch out for the false positive. Where is the pain? Pain should be over the top. This is most important. Same thing can be diagnosed in the O'Brien's test where the patient is complaining of pain in the over the top. So that is there's a forceful adduction towards the opposite shoulder. Patient will complain of pain over the top. That is a scalp test, which is possible, which is positive for the AC joint. Now the scapular pathology, and is basically most important scapular pathology is scapular dyskinesia. Once we elevate both the shoulder, the scapula recedes away from the midline, and we have to examine the length, the area with which is traversed by the inferior angle of the scapula, and if it is equal, that is a scapular migration is scapular migration is symmetrical. That is a scapular dyskinesia. If there is a less than, if the less than the difference is more than 1 to 1.5 to 1.5 centimeter in between this diameter, this is known as the scapular dyskinesia. So we have to examine the area traversed by the scapula during the elevation of the shoulder from the midline. So, and then in the journey of that, if you assist the assistance, if the scapula is not going in the same rate in the other side, if we push the scapula and that there is no pain at all, this is known as the scapular assistance test. Basically, it is due to the serratus anterior palsy or the inferior trapezius palsy. So, summary of the test. So we have to examine the specific muscle function. So supraspinatus, infraspinatus, and the subscapularis. Now, for the instability, we have to choose the position of instability, that is abduction external, the position of instability. Along with that, if we push from the anterior for the for the anterior instability, if there is adduction internal rotation, is the position of instability, the posterior side. Same thing if we push from the back, push from the front, that is the position of the instability for the posterior. So, so this is the position for the unstable shoulder. For the impingement, we have to examine for the forward flexion as also the internal rotation. Forward flexion elevation up to 90 degree and internal rotation and the adduction. This is the position where the head impinges against the glenohumeral capsule. So that is the position of the impingement. Whereas the abduction, external rotation, and the biceps contraction, it is the labral tear. So if we mention this, if we remember this, we can easily identify what are the specific tests. And at least one test should be remembered by each student for diagnosis. And lastly, the cross-body adduction, forceful adduction of the shoulder towards the opposite shoulder. If the pain is complained of on the top of the shoulder, that is due to AC joint. I think this is the examination of the shoulder joint. So is there any question I can ask? I can answer this. Otherwise, we go for the elbow. Over to Abhishek.
Yes, sir. So any question? Anyone wants to ask any specific questions? If we have anyone who can who would like to ask some specific questions about the shoulder examination. And sir, as I have been asking the other people also, so what extra points do you would you like to add, so regarding the common mistakes which the student make during the exam, sir?
Yes, that is why I'm showing some. Suppose this is the case where the pain in the overhead activities. So what are the possibilities? So once we have got that case, we have to ask these. There are several possibilities. Like it may be the slap lesion, it may be due to acromioclavicular joint osteoarthrosis, or it may be due to bicipital tendonitis. So there are some differential diagnosis. It may be rotator cuff disease, it may be painful out syndrome, lateral medium pain, So in that case, what are the points to be looked on? So yeah, in that case, there's a lateral medium pain on lifting weight. We have to see the range of motion and the specific test. For the slap lesion, it may be some, maybe like it will look like the day-down syndrome. So these are the way we have to think of. It cannot be the case of the arthritis, or it cannot be the, we have to do how to rule out the arthritis. So suppose there is some tubercular arthritis. So in that case, there is a monoarticular, it may be some long duration, it may be some systemic features. So, but if in this pain in overhead activities only, so it cannot be the case of the arthritis. So we have to understand in this manner how to think of in such of cases. There are three conditions we have to consider about. So the slap lesion, it may be day-down syndrome, like the loss of velocity and the control due to pain and the uneasy. There is a reduced intra-rotation and the abduction in slap lesion. In the AC joint, there will be joint tenderness and a mild, there is night pain during the recumbency on the affected shoulder, and the bicipital tendinosis, there will be anterior shoulder pain. There is a painful snap or the click in the young athletes from internal to external rotation. Now, one by one, if it is a slap lesion, so there are several causes of the slap lesion. This may be asked in the next slide, so you have to keep it in your mind. Now, basically, it is a traumatic separation of the superior labrum extending from the anterior to posterior, and there are some special tests I already described. And once the child, on the student thinks of these are the possibilities, then you have to think of which cases, which tests I can show to the examiner. So, what are the causes? What is the lesion? What are the causes, and what is the clinical test by which you can easily diagnose? Now, with the AC joint, why it is AC joint? What are the points in favor? The pain is common symptom during the overhead walk. There is a local tenderness. Then night pain during the recumbency on the affected shoulder. These are the cause. So what are the special tests of the AC joint? That is a scarf test. That is a forceful adduction. And we have to think in your mind that at least we have to show these different steps of this scarf test. Now, the bicipital tendinitis, there's a tenderness in the bicipital group, especially during the external rotation. Now, we have to think of what is the method of identification of the bicipital group. So that means we have to identify the greater tuberosity first, followed by the bicipital group. Then we have to see we have to think in your mind what are the tests usually asked for diagnosis, like maybe due to Yardgarson's test, speed test, which may be due to some what are the tests, what are the different steps to for eliciting the test. We have to keep it in mind. Suppose this is the case. So what is the diagnosis? So that may be, if you can think from the superficial to deep, that may be a swelling, that may be a soft tissue swelling, it may be a lipoma, or it may be a neurofibroma, or it may be due to from muscle swelling, it may be due to some neoplastic lesion of the muscles. It is mostly coming from the supraspinatus, infraspinatus. But see, there is a large swelling which is crosses the spine of the scapula. So it may come from the bone also. So if it may be osteochondroma, or it may be due to some winging of the scapula. That means that there is a paralysis of the serratus anterior. So these are the differential diagnosis. We have to keep it in our mind. We have to go one by one.
Yes. So the students have to keep in mind the
Exactly.
differential diagnosis and everything when they are approaching a case of shoulder. Exactly. Right, sir. Right. And
any other question?
Yes, sir. So anything else you would like to mention about the shoulder, or should we proceed with the elbow presentation? Like
any other question? Any other ask them? Any other question is there?
Students, if they have any questions, they can ask sir directly in this thing. So I don't think there are any questions right now. So yes, sir. So I think you can proceed with the elbow examination. So I think that will be right.
Okay. So we'll start. Okay.
Right, sir.
Okay. So all of you know, just I'm not going into detail because it is very, very common in our examination. So elbow case, I think is one of the, every student will get that case. So in inspection, we have to, so we broadly categorize the orthopedic examination to 7 broad categories, and each broad category is subdivided into 3 subcategories. So large broad categories, the attitude deformity, next is the swelling or wasting, and the skin abnormality. So suppose this is the case. This is the case. So how to examine? What is the basic way of examining this? So always ask the patient in standing in anatomical position in this manner. So
elbow examination should be started from the standing position. Patient should stand.
So patient should stand in anatomical position in this manner, as you can see here, and from spine should be straight, limb should be parallel to the body, and have to examine from the front, from the side, from the back, like this. So if you see from this is the case of cubitus valgus deformity, isn't it? So this is the case. Can anybody join this to diagnose what can be called in this? This one? Can anybody tell? Elbow has some natural elevation and depressions. We have to see these natural depressions. Now see, this is some flexion deformity. Along with there is some coronal plane deformity. So this case cannot be called as a that is a cubitus varus deformity, isn't it? So because there is a mixture of the coronal plane deformity as also the sagittal plane deformity. That is why this case should be called as the gunstock deformity or the elbow stiffness. See, there's a flexion deformity. At the same time, this is another case. You can see there's overt cubitus valgus deformity. But on the right side, the elbow is completely straight. It is completely straight. Which condition is called? This is known as there's cubitus rectus deformity.
Rectus deformity.
Yes, yes. See, this is a cubitus rectus deformity. Now, inspection not only concentrate on the elbow, but also you have to concentrate on the hand also, isn't it? See what is happening in the hand. See, there is a clawing. It is the ulnar clawing. And what is the primary deformity of the ulnar clawing? Is basically a loss of extension of the metacarpophalangeal joint. This is usually asked in the examination. And now, which sort of ulnar clawing it is? It is a upper ulnar clawing, or the lower? It is a lower palsy or the upper nerve palsy. It is asked in the examination. Why it is called ulnar nerve palsy? Why not other nerve palsy like this? So this is a cubitus valgus deformity along with some ulnar clawing. Okay, and basically it's due to say the lateral condyle fracture. Now this is another case. See, these are the swelling. You can you see here? There's significant swelling, but don't concentrate on the swelling, but also there is some wasting also. So in which area we have to examine for the wasting? The wasting should be examined by the maximum muscle bulk. So for that reason, see, this is not the way. We have to expose these biceps, because biceps is the most common area. See, in that case, it is seen somehow, but it has to be exposed adequately. And so there is that wasting of the biceps. Not only that, for the upper limb, for the arm, we have to examine the wasting of the biceps. For the forearm, we have to examine the forearm, especially in the upper part of the forearm. So see, because the maximum muscle bulk is situated on the upper third, not in the lower third. So also always examine the upper third. So if you examine on this side, this is completely flat. So there is a generalized wasting of the whole of the left upper limb. So this is there. As you can see here, as also you have to examine the hand also. For this is the wasting of the hypothenor, as also the thinner muscles also. So this is most important. So we have to examine. There is a generalized wasting all over the body. Now inspection. There is if you see here carefully, what is the abnormality as detected? Can you tell here? Anybody on the right side? There is some swelling. There is a localized swelling in front of the elbow. It is not crossing the elbow crease, but just below the elbow crease, there is a swelling. So ask the patient to flex it. So there is a restriction of elbow flexion. You can see here. So what is this? So we have to identify this swelling. And if we palpate it carefully, there's a rounded bony mass is palpated just in front of the elbow and is rotating with the rotation of the forearm. Basically, it is a radial head. So this is basically it is a Monteggia. It is a unreduced Monteggia fracture. So that may be the, but if the swelling traverses above the elbow crease, that could be the different one. And there is a significant restriction of the movement, that could be the myositis ossificans. Now, inspection from the side, as you can see here, inspection from the side, there is diffuse generalized swelling, non-tender on palpation. See, there is diffuse generalized swelling over the arm, over the forearm, as also over the hand. So this is a case where this is the case. So basically, it is a patient has had irradiation following the resection of the tumor of the breast, and patient is complaining of severe swelling all over, generalized swelling all over the limb, along with restriction of the elbow motion. So basically, it is mechanical. It is due to the accumulation of the tissue fluid, body fluid. Is generalized edema. This is localized edema due to irradiation of damaging of the lymphatic tissues. So how to palpate the in such a case?
Suppose this is the disease tempo. You have to examine from this. This is normal side. This is the abnormal side, and this is the normal side. This is the temperature. Now the tenderness, for the tenderness, you have to palpate the bony points. So as you identify the bony points, the lateral condyle. So lateral condyle is started from this.
These are the tests usually asked in the examination.
Relaxed, so that the border is running on this. So our rule of palpation is to palpate at the right angle with the help of the three pulse, like this. Three pulse. This is the lateral supracondylar ridge, and the bony points, which is downmost and outermost bony points along the lateral supracondylar ridge. This is the lateral and supracondylar ridge. Yes, this is the. Yes, this is the lateral epicondyle. Just below the lateral epicondyle, there is the radial bit. So this is the lateral epicondyle. Now come to that side. Yes. Get to that this side. You have to flex it. You have to palpate. This is the medial supracondylar ridge. The downmost and innermost bony point from the medial supracondylar ridge. Okay. Downmost and innermost bony point. So this is the medial supracondylar ridge. Okay. The olecranon, you have to see the palpate, the right angle, the subcutaneous border of the olecranon, and the topmost point is the tip of the. Yes. So how to confirm the similar thing you have to do with the palpate like this. See, this is the medial epicondyle, this is lateral epicondyle, and this is the olecranon. Similarly, you have to point it out like this. Medial supracondylar ridge. You have to palpate most uppermost bony point, the tip of the olecranon, the lateral supracondylar ridge.
So this is the way by which we can compare the different relative bony positions of the three bony points.
This is the bony points. So this is the interepicondyle distance. This is the medial arm, and this is the lateral. Yes.
So this is the way by which we can easily understand the relative position of the three bony points. Now, inspection from the back. Suppose this is the case. This is on palpation. There is a locally circumscribed local non-tender form swelling. There is a local non-tender form swelling, and there is a soft end point. If you see, ask the patient to flex it, you have to see the soft end point. So basically, it is a soft tissue swelling on the back of the shoulder, back of the elbow, which is causing the mechanical restrictions. So how to examine this?
Suppose this is the disease tempo. You have to examine from this. This is normal side.
Okay. So this is another case. This is a localized swelling of the point of the elbow with reddened glossy skin. So it is an inflammatory swelling. And if you ask it's a simple aspiration that will lead to the hemorrhagic fluid. Now on inspection, there are different types of scar you can see. So these are the simple. These are the see. There is some puckered scar which is superficial, which is extra-articular. It's extra outside the elbow. But because of this addition, there is some restriction of the elbow motion. So there is an extra-articular block. But you see, there's a puckered scar which is attached to the underlying structure, the underlying bone. So on attempt of doing this puckering is increased. That suggests that it is attached to the underlying bone. So there is basically it is suggestive of the infective lesion underlying. So it may be the chronic osteomyelitis. So you have to palpate the bone carefully for its thickening, broadening, and irregularity and the tender. Now, this is another scar, which is headed. It is healed with secondary intention, opposite to the joint. So that may be due to intra and extra-articular. It may require a longer time. So that may lead to intra-articular as also the extra-articular fibrosis. Now, the range of motion. How the range of motion? There are 3 points. We have to see whether the range of motion is starting from the deformity or from this neutral position. Next, we have to see the arc. And with the stop, whether the stop is the hard stop or the soft stop, and association of the pain. Suppose this is the case, the range of motion is 0 to 140 degree on the left side is absolutely normal. On the right side, see this it is due to terminally painful. See the face. So association of pain, it may be terminally pain, which the whole arc is painful. So how it can be examined? See this.
Examine the elbow motion. So elbow motion can be examined like this manner. In this manner. Suppose you have to relax and see whether how much extension is possible. How much extension is possible from this? So this is the hyperextension, paper of hyperextension. And from that, ask the patient to flex it. Flex it to touch the shoulder. Yes. So see, if you can see from this side, you can easily compare the range of motion. Whether it starts from the deformity, 1-0 position, neutral position, what is the range of motion. So this is the angle. Now see, from this side also you can examine like this. Yes. Examine like this. Now this is the starting, this is 0 position, exit, watch out. Yes, so this is the range of motion. This is the range of motion. Okay. Now how to examine the forearm motion? Forearm motion is just you have to keep both the sides so that to negate the rotation of the shoulder. Now this is the neutral position. Let's see, this is the neutral position. Either you ask the patient to hold the pain or you have to hold it like this. This radial styler process. Now ask the patient to rotate like this. Yes, see, and you have to see the range of motion like this. This is this range of motion. The supination and again the shoulder. Now, yes, compare the movement of the radial styler and see the range of motion. The range of motion. See, yes, see the range of motion like this. So this is the forearm motion. Right.
So we have to examine the range of motion in this manner. See, this is the flexion deformity. There is a 15 degree flexion deformity along with the range of motion is 15 to 90 degree, and it is absolutely painless. And how to examine accurately examine the range of motion? So keeping the limb in or on a hard surface or with the help of a hard ruler, we have to examine this. Suppose this is a flexion deformity is the 30 degree and associated range of motion 30 to 120 degree like this. So we have to place the goniometer. By the center of the goniometer should be placed on the epicondyles, either medial epicondyle or on the other side is the lateral epicondyle. So this is another case, 2 scenarios. They see in this case, there's hyperextension is seen and the flexion is same, as you can see, both the same. This is the one, hyperextension is there, but the flexion is same. Whereas in this case, the hyperextension is there on the right side, but the flexion is restricted. So what is the condition? So this is the case where there is a normal. So it's a normal. You can see here, this is normal case. It is a normal, whereas it is a case where there is a restriction of elbow motion. So that restriction of flexion at the cost of hyperextension. That is because of the malunited supracondylar fracture, as you can see here. So this is the another case where how to forearm motion is elevated, forearm motion. And see the clinical detection of the persistent components of the displaced supracondylar fracture. So that may be due to medial tilt, it may be medial rotation or the posterior tilt. Now how the medial rotation is ascertained, that is basically due to we have to examine the shoulder motions. As you can, how to shoulder motion is examined. You have to examine in this manner, either by the side or by the 90 degree, you have to examine the shoulder motions, as you can see here. So this in that case, there will be the excessive internal rotation at the cost of restriction of external rotation. This is the condition, but the whole arc should be same. So that is as the whole arc is same, that restriction of in external rotation is not due to shoulder. It is due to internal. It is due to elbow. So that is the indirect way. And there is way by which this is the persistent medial rotation is due to this Gerber's test. As you can see here, this Gerber's test that is just ask the patient to elevate the arm, elevate the forearm above the body, and that can be easily identified. And this is a persistent medial and the dorsal tilt. As you can see here, this is that's just a comparison of the 3 bony points. This is the tip of the olecranon, and medial epicondyle is at a higher level, as you can see here. So that this whole triangle is tilted medially, and this is the persistent medial tilt. As also in this case, this is the hyperextension at the cost of restriction of the elbow flexion. That is because, see, this is substantiated by radiography. This is a medial tilt, persistent medial tilt, as also the posterior or the dorsal tilt. Now, measurement of the arm length. How the arm length is measured, you can see here.
Measurement of the elbow. Actually, starting point should be the angle of abdomen. How to identify the angle of abdomen? This is the spine of the scapula. We have to perfect like this. Spine of the somatic goes right out, right with bends its character. So this is the angle. So this is the angle actually. We have to identify this. This is the angle of abdomen. Yes. And already we have identified the downmost and outermost point. This is the lateral eccentricity. Yes, so we have to measure it in this manner. This is the length of the arm. Okay. Now, how to identify the length of the forearm? We have to identify the staggered process. So this is the radial staggered process. This is the ulnar staggered process. The radial staggered process is 1.25 cm below the ulnar staggered process. So this is the ulnar staggered process. We have to examine the length of the forearm. Length of the forearm is measured. So this is from this point to this point. So this is the length. How to measure the carrying angle?
So there's drawing of the carrying angle. How to draw the carrying angle?
How to measure the carrying angle? So basic prerequisite of carrying angle is elbow should be completely extended and fully supinated. So if there is no extension, there is lack of extension and lack of supination, carrying angle cannot be measured. So we have to examine it. It's fully extended and fully supinated. This is the prerequisite. Next one is the upper point of the carrying angle. So this is the fold. This is the maximum bulging point on the outer side. So this is the lateral point. You have to measure it.
So I think your this internet is experiencing some problems, sir. Hello. I think we have lost AK Palsa's, I think, connection. He has received some, I think, some internet problems and that. So I think it will be better if we proceed with, I think, Berasa's presentation for the time being. And I think if Dr. AK Palsa comes back later on, I think we can finish off the examination of the elbow, starting from the carrying angle and that. Dr. Berasa, are you online? Achha, sir has come back actually.
Hello? Hello?
Yes, sir. So you can, sir, you restart.
Hello?
Hello. Good evening.
Hello.
Hello.
Yes, sir. Sir, I think AK Pal sir has just come back. Actually, he was experiencing some problem in the network, so we'll just allow him to finish
Hello?
up quickly. Yes, sir. Sir, can you hear me?
Okay,
Hello,
yes,
hello?
sir. So, hello, Abhishek. Hello.
Yes, sir. Yes, sir. Can you hear me, sir?
Let Dr. Pal continue. It's 9
sir.
o'clock. Don't worry. Okay, don't mind. Okay.
Sure, sir. Sure. I will just inform you when the presentation is over from AK Pal sir. I think that will be better. Right.
Okay. Let us stop. That will be the separate day. Okay. Let Dr. Pal end the talk, and then the program should be over.
We will be having a little bit of discussion on the instrument. I think we will just try to get AK Pal sir online again. And that, sir, are you online, sir? AK Pal sir?
Okay. So let Dr. AK Pal continue. Okay. And
yes, sir.
Instrument is not that much important. Don't worry. Okay.
Right, sir. I'll just update.
Hello? Am I audible? Hello? Hello?
Sir, we can see you now, sir. Sir, we can see you now, sir. Right, sir.
Hello?
Yes, sir. We can see you now, sir.
Hello, am I audible?
Yes, sir. You're audible, sir.
Is my sound audible? Hello? Is my sound audible? Okay, I'm continuing. Okay. চলছে না কেন এটা? So this is the posterolateral rotatory drag test. Among all the stability tests, this is the most important test. As you can see here, we have to hold the upper limb in my axilla, and we have to press the forward. There is an axial load as well as there is internal rotation, as also some valgus stress. So this is the posterolateral rotatory drag test. If you have to see on that side, if there is some prominency or the pain, development of the pain or the dimple, or there is something is coming out, that is the radial head, that is indicating of this instability. This is posterolateral instability. And see, these are the different steps as I can show here. First, you have to stabilize the upper limb, and next you have to give some valgus stress, then some internal rotation of the forearm, and give some axial load. And to see on this level where if there is some development of the dimple or development of the swelling due to some radial head which is coming out, basically it is due to the dislocation. And this pivot shift test is basically some flexion to extension. Hold the limb in this manner. This is a fully pronated, and this from flexion to extension, give some axial load and valgus load. We have to see on the radial on the site of the radial side whether the radial head is coming out or not. And this is a dynamic test. Say the dynamic, ask the patient to elevate, to get up from the sit with the help of this limb in this manner, or making this like this is sitting position. This is the prone position, and in that case, patient is unable to get up with the help of this the upper limb, and that can be easily possible if some support is given from the back. So that indicates the posterolateral rotatory instability. Another is the varus valgus test. Varus valgus test is there. So this is at 0 degree and 30 degree. So this is a simple varus valgus test. Stress test can be tested for the collateral ligament, so the radial and the medial collateral ligament. So if the valgus stress test in supination, that is due to the medial collateral and the lateral collateral ligament, whereas in the pronation, there is anterior band of medial collateral ligament and the medial collateral ligament in 25 degree flexion. And see, this is the same thing. I'm showing this. The 0 degree at 0 degree, and see, yes, it is 0 degree. If it is at 0 degree, there is valgus test is positive. It is due to some bony problem, whereas at the 30 degree flexion, 25 to 30 degree, it is due to collateral ligament. And see, this is the posterolateral instability. It's a pivot shift test from flexion to extension. Yes, this is a valgus test is done. Axial load is done. And see, this is the dynamic stability. I'm not going to show, but don't forget to test the joint proximal and the joint distal, and lastly the neurovascular reticuloendothelial system. That will complete the examination of the elbow joint. I think this is in a nutshell. I'm just going to details that is in a nutshell. We have to see we have to follow the rhythm of examination. That is inspection, palpation, movement, measurement, joint proximal, joint distal, as also the neurovascular reticuloendothelial system. In each kind of broad heading, there will be 3 subheading. In the inspection, we have to see the attitude deformity. Next is the swelling, wasting, and the skin abnormality. And whereas in case of palpation, we have to examine first we have to palpate the temperature. Next is the tenderness, the bony points, followed by if there is a swelling, examine the swelling, and lastly the range of motion. Always examine the normal side first, then the abnormal side, then the compare. So in any abnormal side, always to start whether it is starting from the 0 position or from the deformed position. Next is what is the arc of motion, what is the association of pain. If it is a terminal association of pain, it is due to the synovitis. Whereas the whole arc is painful, it is due to arthritis. Lastly, the measurement. Measurement is the arm length and the forearm length, and also the carrying angle measurement. This is most important. If there are some prerequisites of carrying angle, as that the elbow should be completely extended and forearm should be fully supinated. And lastly, the joint proximal, joint distal. We have to examine the shoulder also, as also the wrist, just a quick review. That is, we have to examine the wrist for this. This is the this dorsiflexion. This is the palmar flexion, and you have to see this is the radial deviation, ulnar deviation. About the shoulder, there is also forward flexion, abduction, external rotation, internal rotation, as also the extension. So, and in the proximal and distal joint, always examine any deformity, whether in tenderness and the range of motion. These are the 3 points should be examined. And lastly, we have to see the stability test. As I can show you, I showed you there's a posterolateral instability and the MCL cell test, and also the neurovascular-reticuloendothelial system. So this is the way by which you can easily examine the elbow. I think, is there any question I can discuss along with that? Any question?
Requesting the students to have a talk if they want to ask something to AK Pal sir. I think we had a little bit of disruption in between regarding the internet connection. The sound went off, I think. Okay.
Any question I can discuss? 76053.
Right, sir. Again, what is the main target of our program? We have been trying to get this at the elbow examination, the common mistakes which the student make. The same thing which I asked you during the shoulder examination. If you could kindly elaborate that, should not be an issue. Dr. Pal sir, if you could kindly elaborate. So I don't think we have any questions as such over there. So I think so you can just have a talk about.
So is there any no other questions?
No, there are nothing questions. I think we will ask. We will see if Dr. Bera sir has got free from the OT and if he can give his presentation now. I'll try to connect with Dr. Bera sir and just try to see if he has finished his OT and he can give his presentation on the instruments right now. So I'd request you to stay online because sir was also requesting you to be online for the instrument session, so that we can get some input from you as well, sir.
Okay, definitely.
Academic, right. Dr. Vedat, sir, are you online? Sir? So I think sir is busy in the OT. I think we will just run the presentation because sir had already sent me the presentation over there, and sir was with us in the the early session and that. So I think it will be I think it will be great if you can just guide us through the instruments in the same time. I think that will be a better thing. I'll just start the presentation. Try to start it from my laptop.
You start the presentation.
Right, sir. Right, sir. So I think you can see this thing, sir. I think you can. I think Dr. Bera sir can join us in between if he's free. I think he's busy in the OT right now. So I'm starting the presentation, sir. If you could kindly like unmute yourself and then over there we can talk. Right.
Please start.
Yes, sir. I've already started it, sir.
For the students, I'm going to do the introduction. For the instruments, I basically just before that, I'm going to have just two sentences.
Right, sir.
First of all, the instruments, there basically this is very important. There are 4 tables in instrument. There will be you will given 2 instrument. One will be instrument and one is the implant, and there will be operation technique. Okay, so we have to answer the one instrument and one implant and operation technique. So basically, I'm going to give the tips. So what are the basic questions asked in the examination regarding the instrument or the implant? So that is what we have to tell the nomenclature. We'll tell the instrument. Yes, marks is 10. It is okay. We have to identify the instrument. What is that? To tell the name of the instrument first. Next, we have to tell the different parts of the instrument, and then what is the different parts and the utility. Next is the indications in which operation it is used, and next is what are the advantage, what are the disadvantage, if there is any modification done or not, and lastly the how it is sterilized. So this is the common questions easily asked in this examination. Okay, start with this.
Yes, sir. So I've started, sir. So this is the intention which like it is used for day-to-day usage, and there are the various instruments which they use. So would you like to make any comment on this, sir?
Yes, inventor. Yes, sometimes inventor's name is asked, and if it is very much popular, there are several along with some instrument. If they invented some techniques, so in that case, name of the inventor is also asked. Yes, it is right. And most of the points which I have told, that is already it is mentioned. Okay, carry on.
Right.
Next.
Right.
Next.
So any comments on the new instruments?
Yes,
which sir
I've
has
already
mentioned
told from suppose there is some reamer. Suppose there is some one reamer is given for the osteoprosthesis or the hemi replacement of the femur. So in that case, examiner asks, can you tell any special type of reamer which is available for the for preparation of the calcar? So there is known as a calcar reamer. Calcar reamer is a special reamer. So from basic instrument, the student may be asked to tell the advanced instrument. Okay. So in that case, a new instrument for usage, sequences, population variances, individual variation. That means improved technique and also feedback. So these are the questions usually asked in the examination. Next.
We are still waiting for sir to come actually, like, to come online actually.
You have to identify what is it?
Yes,
Can anybody identify this?
so any comments? Any comments? Yeah.
Previous.
Yes, sir. So it is actually ahead, sir. Actually, I'll just go a little bit ahead because sir had actually must have had a talk, or like he must have planned a sequence of instruments. Yes, sir.
Yes.
So if you can make some comments.
Can anybody
on this
identify?
instrument. Right.
What is this? Can anybody identify? Volunteer, please.
So this one is like, so if you can make a comment on this, sir, this is like the.
Yes. So, say, what is this? Can anybody identify this?
I think no one is like online and that. So I think we can proceed with the identification, like the straight reamer, what we are like.
Yes.
Yes, sir. So this
is a reamer, I think.
Yes, sir. So this is straight reamer.
It's a hand reamer.
Hand reamer.
Hand reamer. Now we have to identify the instrument first. This is a hand reamer. Basically, maybe intramedullary. This is a hand reamer for the intramedullary nail, intramedullary nailing.
Absolutely.
Now the once we have identified it, now the next question will be what is the size? What are the different types of the reamer? Right. Now for which bone it is used? So these are the questions usually asked. Now what are the advantage and what are the disadvantage? What are the advantage and disadvantage means advantage of the reaming, advantage disadvantage of the reaming is that. So so what is the purpose? What is the part? What is the part where this reaming is done? What is the purpose of the tip? What is the purpose of the slot? Can anybody tell? Now, how do you know the reamer is working well? Function is working capacity of the reamer is well. So we have to see the tip of the reamer. In the tip of the reamer, they have to see the inclined angle. There are two inclined angles, which is known as the rake angle. If the rake angle is a positive rake angle, that indicates it is a sharp reamer. If it is a negative rake angle, that is it is a blunt reamer. So if it is a sharp reamer, so in that case it will cut much more efficiently. But if it is extremely sharp, then it will cause increase of temperature. Along with the cutting of the bone, that will increase the temperature. Whereas if it is a blunt reamer, so in that case it increases the temperature only, but it does not cut. So that is the advantage and disadvantage. Now, what is the function of the slots present in this? See, there are some oblique slots up there. See, these slots are, once we cut the bone, so these slots are basically there to remove that bone debris. This is extremely. So once the bone, if the bone debris are not removed, so in that case, if the bone debris are accumulated, that increases the temperature formation. So if the temperature will be more, that will cause much more necrosis. That is the most important point. So that basically is a non-cannulated reamer for the intramedullary nailing. It may be I can't see the inner aspect. It may be cannulated or it may be non-cannulated to see whether it is cannulated or not.
Right, sir. Looks to be non-cannulated on
other variants. Other variants is a cannulated reamer.
Yes.
So these are the questions usually asked. And also other advantage of the reaming is if there is reaming products, they may act as a bone graft. There is a micro bone graft. This is the advantage. And what is the disadvantage? Disadvantage is basically if it's a reaming product, if the reaming is there, that can lead to some the reaming product may embolize, and that can lead to pulmonary embolism. So we'll give some precautions. So precautions are prophylaxis against the pulmonary embolism.
Right.
These are the questions usually asked. Now, what are the other advanced variety is the power reamer. Okay, so this sort of questions usually asked.
Right.
Now, what is this? What is the name of this? It is a common mistake. It is a very common mistake by the students. They are telling it is a all. It is not not all. It is a brad all. Yes. Because the all doesn't have an eye.
Right.
Brad all has an eye. So this is basically it is a brad all. It is a straight brad all with wooden handle. So this is the actual description. And again, you have to see whether it is sharp or blunt, depending on the rake angle. The rake angle is basically it is for making the the holes in the bone or the soft tissue. So if the rake angle is a positive rake angle, then it is a sharp one. It is a negative rake angle. It's a blunt one. And if there is eye is there, if it is a brad all, if it is no eye, it is all. And basically, yes, this is their function is to introduce some sutures. From distant site. Okay. Now, what is this? What is this? See, This is one screw is there, and there is above over the top there is another. There are two pieces. Two pieces are attached with some thread, and over the upper part of the metal. It has a hook-like attachment, isn't it? So basically, it is a Muller's compression device. Muller's compression device.
Right.
It is basically it was previously it is used for compression at the fracture site when there is no advent of the dynamic compression plate.
Right.
So in any there is any mechanical plate, any bone plate that can be used as a Muller's compression device. In that case, there's whatever compression may be required, you can do that. With this, but now the knowledge has been why it is now out of the fashion, because it is seen that there is compression of maximally 1 to 2 millimeter is required at the fracture site, not more than that. So that 1 to 2 millimeter compression can be easily achieved by incorporating the technology inside the plate. That is how the dynamic compression plate has come. Though the dynamic compression plate is a misnomer, it is asked whether it is a true nomenclature or is a misnomer. The DCP, dynamic compression plate, is a misnomer. Basically, it causes the compression during the operation, but it cannot provide the compression after the operation. In that sense, it is not a dynamic compression plate. It is a self-compression plate. So basic nomenclature should be static compression plate or the self-compression plate. It cannot be the dynamic compression plate. Two dynamic compression plate which provides compression even after the operation. That was initially it was came in the market, but now it is not in the market. That is the can anybody tell which was the true dynamic compression plate initially came but is now out of the fashion?
Anyone from this thing who are attending?
It is the Eggers plate. It is the Eggers plate. There is a longitudinal slot. There is a longitudinal slot over there. Actually, that screws are placed on the longitudinal slot, long longitudinal slot in the center of the plate, and the screws are placed from above. And once even after the operation, during the muscle contraction, the screws will come closer to each other. But that causes instability, and ultimately there is a loosening of the screws, and ultimately that fails. That is how it is out of the fashion. Now there is no typical dynamic compression plate available in the market. All are basically it is a static or the self compression plate.
So we'll move on to the next instrument, sir.
Yes, next instrument is basically it is a screwdriver with slip. So screwdriver with slip. Now what is the screw? Now question is asked, what is the screw? Screw is basically it's a machine which converts the rotational force into a longitudinal force or axial force. So basically it is a machine, and the screwdriver is just instrument which basically helps that conversion of this rotational force, rotational torque into the longitudinal torque. That is why once we rotate the screw, so that rotational torque is converted into longitudinal torque, and if we insert the screw across the fracture, that causes the axial compression across the fracture. So that is the mechanism by which this screwdriver works. And why this sleeve is there? Sleeve is basically holds the screw head. Why it is important? Because sometimes we are working in a very depth condition. So suppose in a pelvis, so we are going to place the screw in a very deeper situation. So in that case, if we use the normal screwdriver, so in that case screw may fall down, and that it is very difficult to find it out in between the larger wound. So in that case, the screw holding screwdriver can be easily used for that. What are the different other types of screwdriver? Yes, there are some flexible shaft screwdriver. There will be some power-driven screwdriver. These are the different types of screwdriver. So ordinary screwdriver, there are some slip screwdriver with slip, as it is shown over here. There are some malleable shaft screwdriver which can be used in different curved way. Suppose we are going to place the screw in a curved manner, not in a straight manner. So in the acetabular or in the pelvic surgery. So in those cases, the screwdrivers can be used. Okay.
And there are different, there are screwdrivers depending on the
different types.
Screw types. Yes, different screw types. It depends on the types of the screw, diameter of the screw.
Right. Okay. So we can move to the next instrument. And
yes, this is known as the T handle.
Okay.
T handle that can be used. There is a simple traction. This is using the skeletal traction. You can use that, or or there is very important tool for using the joystick reduction. This is also important. Suppose there is a fracture dislocation of the shoulder. So in that case, we want to reduce the humeral head with the help of the joystick. So in that case, what we will do? Well, we have to engage with the help of a Steinman pin, and with the help of this T handle, we can make a joystick so that it can be easily reduced. So that can be used as a joystick tool for reduction method. Okay. Yes. Now this is the metallic osteotope. So there are two varieties basically. This osteotope, one is chisel. How to identify which one is osteotope, which one is chisel? In osteotope, both the side is beveled. Both the cutting side is a bevel. What are the different parts of the osteotope? It has a blade, it has a shaft, and it has a striking surface. These are the three parts. Blade is basically the end of the blade is sharp. If the end of the blade is sharp on both the sides, this is known as the osteotope. But if the one end is sharp, one end is blunt, this is known as the chisel. The same.
So this is the common. So this is the common thing which the students are asked still in the exam, that which is an osteotome and which is a periosteum, I suppose.
Yes. What is the difference between osteotome and the chisel? Chisel, yes. Suppose it is a chisel. What is the purpose of the chisel? Chisel was actually basically manufactured to take the bone grafts, different depths of bone graft, sometimes a small bone graft or a large bone graft. So if depending on the situation, if we keep our beveled the blunt end of the chisel close to the bone, so in that case we can take very thin sliver of bone graft. But if we keep our beveled end over the surface, that is, we keep our sharp edge towards the bone, so in that case we can take the thicker part of bone graft. So this is the way we can take the thicker or thinner part of the bone graft with the help of the chisel. And this is known as the gouge, bone gouge. Yes, bone gouge. What is the purpose of that? The bone gouge is basically that it is used to make the specific hole. So specific hole inside the bone. So, and we have to curate. We have to it can go inside the small cavity inside the bone, and we can take the different parts of the bone over its grooved surface. But it cannot contain it. If you want to contain it, then we have to use the bone nibbler. But here the bone is cut, and the bone may be kept just over the slotted surface, but it cannot be contained. I think Dr. Bera is already available. Yes.
Yeah, I think I'll have a talk with him, sir.
Yes, please, Dr. Bera, please. So I'm giving I'm taking your role actually. So please narrate your cases.
Sir, are you online, sir?
In the meantime, I'm just going to sample tips to the students.
Yes.
Once is asked, what is the general use of general instruments? So basically, I can tell it is remember ABCO. ABCO. It's very simple mnemonic. A for the amputation, B for the bone grafting, C for the chronic osteomyelitis, that the operation for chronic osteomyelitis, that is the sequestration saucerization, and O for the open reduction and internal fixation. And think there's all the general instruments that can be used in four cases, 4 operations. So if you know anyone, become the expert in open reduction, internal fixation, anything, you can utter that, and examiner may take in that line, and you will become succeed. So ABC is a good mnemonics.
Right, sir. And one more experience which I'd like to share from my DNB practical exam when I had gone to Safdarjung Hospital for my exam. So I think they had some pretty good the total elbow replacement processes designed by our own Bakshi sir. I think they had some, and they asked me some questions about that. So like we should also be prepared. Like the place where we are doing our this thing post graduation, we should also know the local instruments as well. That what instruments have been developed over here, or what are the people who have been like over there. So, Dr. Bera sir, are you online? I think sir has a little bit of instrument issue, I think. That,
Abhishek, you continue this showing the slides. I can continue discussion as soon as Dr. Bera is available. He can continue. Okay, so that we can save our time. Okay. Okay, so this is the bone gouge. So in that case, we can cut the bone, we can contain the bone over the surface, but we cannot retain it. So if you want to cut the bone, and also we have to want to retain, there's another important instrument which is required, that is the bone nibbler. Bone nibbler, okay? And here again, there are different types of bone gouge. There are some important, there are modifications of the bone gouge, like some curved gouge. So curved bone gouge, sometimes it is used to cut the excess bone on the lateral aspect of the femur during the arthroplasty. Another important special use for the bone gouge is to form the core decompression. For core decompression, we have to cut this exact 7 millimeter cut of the bone. We can use this bone gouge. Again, see, this is the chisel. Actually, this is the beveled. There is a blunt end is kept over the surface. So this is the chisel, and what is the purpose of the chisel? I've already discussed. That is to take the different depths of the bone graft. Yes, Dr. Bera, please continue your. Dr. Bera. Are you online, Dr. Bera?
I think sir is facing a bit of, little bit of network issue or something. Yes, mostly because I've also been trying to. Sir, are you online, sir?
Keep showing the photograph of the instrument.
Yes, sir.
See, orthopedic is a very dynamic process. So whatever my knowledge may be insufficient enough. So if the Dr. Bera has want to add something, he can join even after my lecture.
Yes, sir. We will definitely wait for him, and we will try to get as much inputs as possible from him regarding the instruments. So.
Yes, definitely. Yes. So I think what is this? Actually, it is. I think it is a cannulated screw. I think it is. So cannulated. Suppose it is a cannulated screw. So in that case, what are the different types of cannulated screw? What is the purpose of this cannulated screw? It is asked. Yes. Purpose of the cannulated screw, it is asked. So basically, cannulated screw is developed for a precise placement of the screw. Precise placement, because if we want to, because bones is a very precise, basically very valuable instrument. So before placing the screw, we have to drill it. So if after drilling, so you want to change the position of that screw, so that an important part of the bone is already lost. So in that case, we have to choose this cannulated screw. So in that case, we have to use the guide wire, and over the guide wire we have to use the cannulated drill, and over the cannulated drill we have to use the cannulated screw. So for that, so that the screw can be placed precise. So how it helps? That help for not only the precise placement, but also it causes the compression, as also that will maintain the exact size of the screw, so that screw will not goes cut out outside the articular process or opposite to that bone, so that may hamper to the joint integrity or the soft. function of this canceller screw, cannulated canceller screw. Right. And but the disadvantage of what is the disadvantage of the cannulated canceller screw? As there is a core inside that thread. So basically that causes some structural loss. So in that sense, it is relatively weaker bony construct than the solid screw. So this is most important.
Right. Sir.
Okay.
So we'll move on to the next instrument, sir.
Yes. I think next instrument.
Yes. So this one is the next instrument. If you can give a little bit of elaboration.
Basically, it is a tap. So why the tap is required? Tap is basically it is required for cutting the thread. So basically, what is that technology of the screw? I already told screw is a machine which converts the rotational torque into a axial torque. Now for the insertion of the screw, we have to make a pilot hole with the help of the corresponding drill bit. Right. Why the corresponding drill bit? Because corresponding drill bit means the screw has a different parts. Screw has a head, it has a shaft, and the junction of the head and shaft is known as the runout, which is the weakest part of the screw. And then the smooth component is the shaft, ultimately ends into the thread. Now, there are two types of thread. One is the V thread and the buttress thread. V thread is basically that is a V like, it is shaped like, if you see from the side, it will look like a V. And buttress means that is one side is a plane, another side is inclined. So these are two types of thread. And ultimately, it ends in a screw tip. There are screw tips. There are different types of screw tip. It may be trocar tip. It may be due to some non-tapping screw. It may be a self-tapping screw, or it may be due to some corkscrew. Corkscrew basically. Right. So it is a trocar screw. Trocar thread means it goes inside by making it the thread. Similarly, corkscrew thread. This is a canceller screw has a corkscrew thread. So it cuts the thread. So canceller screw doesn't require some thread as a tapping, the tap that is cutting the thread. But the cortical screw, because they are inclined, they are intended to insert into the cortical bone, which is much more strong. So in that case, just after making this thread, there's pilot hole. That means we have to choose the thread the diameter of the drill, which is equivalent to the core diameter. So core diameter of the thread should be drilled with the help of this drill bit to make this pilot hole. And after making the pilot hole, the exact amount of the thread should be cut with the help of this that is the tap. And the part how we use the tap. The basically there are one way of using the tap is you have to full turn the tap twice and half turn just reverse. Full turn twice. Right. Yes, and half turn just reverse. This is most important. Why it is important? Because if you see carefully the tap, there is some longitudinal slot. So if we use the thread, if we cut the thread, there's some bone debris will develop. Unless the bone debris will come out, if the bone debris accumulate inside the screw thread hole, that will increases the temperature. So So if the screw threads, if the bone debris remain inside the screw along the screw threads, once we insert the screw, that will cause excessive jamming inside it. So in case of excessive jamming, if we use excessive power, so in that case, there is excessive heat will be generated, and that heat is detrimental for its screw purchase. And ultimately, that screw purchase will be hampered, and that screw become loosened. Right. That is why that bone debris should come out with the help of this tap. And how it come out? That is the way. That is a full complete turn clockwise and half turn anti-clockwise. So if in this manner the bone thread will be lodged in the longitudinal slot of the thread. So after that, if we take the thread out, so in that case, if we easily really examine that, the bone threads are completely filled up in the longitudinal slot. So this is extremely important. So that is how the tap is used. Yes. Right. Now this is the Langenbeck retractor. This is a single-bladed Langenbeck retractor. You can use that for that. Now the question is asked where it is completely mandatory. So what are the different types of instrument which is required for retraction of the soft tissue from the bone? This is one. This is the longitudinal. This is the retractor. Another is the this Homan's forceps, or the bone liver, or the Homan's forceps.
Right.
So now the question is in name one operation where the Homan's forceps are contraindicated. Only this sort of Army Navy type of Homan's these Langenbeck retractors are used to prevent the damage of the nerve along the bone. So this is the question is asked. The answer is just in the upper third of the radius. If there is a fracture of the upper third of the radius, so in that case, so if we go by this Boyd's approach, so that is from the front. So in that case, if we use this sort of bone lever or the Homan's forceps to retract the supinator from the bone, so in that case, what will happen? That may cause the damage to the posterior interosseous nerve.
Right.
So in that case, only this is advisable to use this Langenbeck. Don't use the Homan retractor. So these are the questions, pertinent question maybe.
Right.
Yes. These are the different drill bits.
Drill bits that we have.
I think Dr. Bera is there. Dr. Bera, you can continue.
Right. Dr.
Bera?
I think sir can play the video, and I think sir can just unmute himself, and I think we can, if his range, like the mobile, this thing is okay, then we can have a talk. Sir, are you online, sir? I think, sir, there is definitely some network issue with him, sir. So will sir continue, I think.
Okay.
Yes.
Okay. Show the instrument.
Yes, sir. So,
now we are showing the drill bits. Now, what are the purpose of the drill bit? I've already told. So basically, what are the different parts of the drill bit? We have to see the tip of the drill bit. We have to see whether there is a positive break angle or the not, and see the threads, the slips, the oblique slips, oblique slips of the drill bits. The oblique strips it should be sufficiently deep enough to take the bone, the take it out. Now the question is, what is the technique of taking out of the drill bit? Once you have completed the drilling, how will you take it out? The answer is, we have to rotate in the same manner. That is in same clockwise manner. So you introduce the drill bit, you have to rotate in a clockwise manner. When you take it out, again you have to use the same clockwise manner. This is most important. Don't reverse it, because if you reverse it, all the bone debris will remain inside it. That will not come out. So that is the tips of this is asked in the examination. How will you take out the in which or by which rotation you will take out the drill bit from the after cutting the hole? So that is, and what is the purpose of the drill bit? To make the pilot hole. So, and what is the different types of drill bit? That depends on the screw, and when depending, it is asked. For suppose it is a 4.5 millimeter screw, which sort of drill bit is used? It is basically it is a 3.2 or 3. Now for 6.5 millimeter cannulated cancellous screw, which drill bit is used? Again, it is 3.2. Why it is different? Why it is different? This is asked because in the cannula it is a 6.5 millimeter cancellous screw. The core diameter is very small, and we have to drill only the core diameter. So as the core diameter is 3.2, so we have to use the drill bit 3.2. That is the in cancellous screw. What is there? That is pitch. That is ratio between the thread diameter and the core diameter is higher. That is the basic difference between the cancellous screw and the cortical screw. Okay. Now, this instrument basically it is a distractor. It is a distractor. Yes, it is a femoral. Basically, it is used as a femoral distractor. But now it is other parts of the body. It is used for the distraction. So, what are the purpose of that? So, it is used basically for distraction of the fracture. So suppose it is old fracture or is a fracture dislocation, so that causes the distraction. So suppose it is a fracture dislocation of the knee joint or the supracondylar fracture dislocation, or there is some two-column fracture of the distal femur. In that case, there is a joint spanning femoral distractor may be used. And suppose it is the proximal tibial fracture, same thing is joint spanning distractor is used. So in distraction, if you distract properly, we can easily understand what are the different fracture fragments. So in that case, it is now easy to fix the fracture fragment, and we have to identify the key fracture fragment. It is very important. And once
the placement of the pins is very important. Sir.
Yes, placement of the pin is strategically we have to place the pin so that you can easily distract it, and we have to identify the key fracture fragments and for specific fixation. Now it is a Volkmann scoop or spoon. Volkmann scoop and spoon. Basically, it was introduced for the again the same ABCO. It is a clinical use, common use, and especially it was manufactured for the operation of chronic osteomyelitis, that is sequestrectomy saucerization, where the installation of the antibiotic was the customs of use after curating the bone necrotic tissues and also all the damaged tissues. After that, once it is completely cleared off, now some antibiotic installation can be done with the help of this. Now these are the reductions. Some reduction clamp, specially used for the acetabular fractures. In that sense, it is known as the Matas clamp. So these are the basically reduction clamp that can be used even one prong inside the body, one prong outside the body. So that is why it is. Yes, it is a Matas clamp, Matas reduction clamp used for the acetabular fracture. Next. Yes, it is a plate bender. Now, it is a plate bender. Now, what are the plates can be bended? Now, what are the different types? Basically, there are the plates can be bent in, most of the plates can be bent in 2 axes. And it is longitudinal axis and right angle. But there is another axis. It is at the axis of the same axis of the plate. And there is only one plate which can be bent in also Z axis. So that is the recon plate. So recon plate is basically the plate which can be bent in all 3 axes.
3 axes, right.
But not all other plates cannot only bend only in 2 axes. And this is the plate. This is known as the bending iron. So the plate bending iron. So bending iron can be used for using this bending of the plate in Z axis also, which is specifically required for acetabular fracture.
Right.
Okay. Now this is the drill slip with or without trocar. Trocar may be there or trocar may not be there. Basically, it's a drill slip, and that drill slip can be used to our protection of these other soft tissues during the drilling, and also we are doing tapping. We can use that, and depending on that, there are different types of the drill slip and the drill tap slip. Okay. Next.
And
Yes, it is also a bone clamp. It is a bone holding forceps or clamp. So see what are the different parts? It is basically it is a blade with serrated border, and there is a lever. One lever is a single lever, and a hand with some lock. So it is a self-retaining. It can be called a self-retaining bone holding forceps. There are different types of bone holding forceps depending on the bones where it is used. It may be small, medium, large. Okay.
Yes.
Okay.
This again this thing, sir. Like we can use it in different.
Yes, it is a little bit different. This is basically this. It is another. This is a bone holding forceps.
Yes, sir.
The another types of the bone holding forceps is just shown next on the next slide.
Yes.
On the next slide. The bone holding forceps is basically used for reduction. This is open during the open reduction.
Nice.
Open reduction, internal fixation. For specialized reduction, it is used. This is also a self-retaining bone holding forceps.
And this is
But this is the one. This is, like you can see here. This is basically the plate holding forceps. As you can see here, it is a blade. It has a blade, as also it's a lever, and also the blade. It's a handle with some locking system with some lock.
Yes.
So once
money clamps, sir. I think this has a the southern part of the country, we have a clamp like this, which was designed by Professor Mani, I suppose. It was known as the money clamp, I think. Yes.
Money clamp.
Money clamp. Yes.
Yes. So basically, it holds both the bone and as also the plate.
Yes.
Yes, this is also some different modification of this. See, there are some. This is also plate holding forceps. You can see here plate holding forceps. It is inclined so that it can walk from a different angle. So for better surgery, it can be used.
Right.
Yes. Now this is the bone cutting forceps. It's a double levered. This is a double levered bone cutting forceps. See, what are the parts? It is a blade. This is a two lever. You can see here, two lever, and it's a handle. It's a handle. Now, how the double lever helps? So, for the double lever, if you just a single force is applied on the handle, it is augmented. It is augmented at least 3 times on the cut surface.
By the action of the levers, sir, and that over there.
That is the function of the double lever. Yes, this is double. It is almost it is doubled or tripled at the cut end.
Yes.
Yes. Now this is also that it is either a towel clip or it can also be used as a reduction forceps. There are different purposes of this. There is reduction of the bone. Suppose the reduction of the tension band varying of the patella. Yes, these are also there's a patella holding forceps.
Right.
See, there are some guard is there at the end of the pointed end. There are different types of this type of forceps. This is typically patella holding forceps, but there are some other forceps also. Now, see, this is the instrument which not only cut the bone but also retain the cut portion of the bone. This is also the double levered bone cutting forceps with parrot beaked end. This is the parrot beaked end. So why it is important because of this parrot beaked or inclined head that will act from different angle in a depth perception in a deeper area. And not only it cuts the bone, it also contains the bone. So it is used for cutting the bone in the tumor surgery, as also during the spine surgery, and also during in any operation where there is some bone may be reshaped.
Right.
That can be used. Right. Yes, this is also a bone retractor. This is the different bone retractor, and because of this sharp edge, that can easily is used for retraction of the sharp areas.
Yes.
Yes, this is also there's a double levered bone cutting forceps, or but see, it's not a bone cutting forceps. It is a wire cutter. Yes, it is a wire cutter. How it is different between the bone cutting forceps? In bone cutting forceps, the cut surfaces blade is much larger, but here it is the blade is small. So that is why it is not a bone cutting forceps. It is a wire cutter. So it is used for cutting the 2.5 millimeter wire.
Yes, right.
If it is larger one, there is some jumbo cutter is required.
Yes, sir. So that is normally what we use for the titanium elastic nails and the other harder implants. Sir.
Exactly.
The jumbo cutters. Right.
Exactly. Yes. See, this I think it is a ball-tipped guide wire.
Yes, guide wire and that thing.
The ball-tipped guide wire. It is used specially for making the hole at the point of the junction of the junction of the pipe structure. Which is the entry point of the pedicle screw.
Yes.
Entry point of the pedicle screw. There's a junction of the lamina, junction of the pedicle, junction of the superior inferior process, and the transverse process. Exactly. This is the point. This is just maybe the medullary process, maybe the entry point to make it the entry point of the pedicular screw insertion that can be used, because just this very small cutting point, along with that just before that there is a large stop is there. Okay. So this
1 minute. I'll try to get the instrument before this.
Okay. Yes. Next one.
Yes, sir. This one, sir. I think this is the sinus forceps, sir.
It may be sinus forceps. We have to preferably it should be open. If it kept open, it would be better to be understood.
Better to see. This is our standard towel.
Yes, it is a Chittle forceps, or it is a swab holding forceps.
Sponge holding.
Swab holding forceps. Yes. Especially during if it is given, then you have to use what are the sequence of antiseptic dressing? Why it is what is the scrub? which sort of scrub is used. Is it is betadine? Which sort of betadine is 2.5%, 5%, 7.5%, 10%? Usually for the scrub, betadine is 7.5% scrub is used.
Right.
After that, how antiseptic dressing is given? So antiseptic dressing is given initially by the betadine. Then the first is the betadine scrub, followed by the rectified spirit, followed by the betadine 10% betadine.
Right.
Okay. So why? What are the purpose of giving this betadine last? Because betadine has it requires some contact time. There's 5 minutes contact time is required.
5 to 8 minutes, sir. I think.
Yes, 5 to 8 minutes. 8 minutes. 5 to 8 minutes contact time is required.
Contact is required.
That is why it's increasing. This sort of question may be asked.
Right.
Which type of blade it is? Different types of blade. There's a first upper blade is, I think it is a 20, and the lower blade is, I think it is a 10. I think.
15. Yes, sir.
It is 15 and it's a 10.
It's a 10. Yes.
Yes. So for the soft tissue injury, for finer surgery, we can use that. And for the fast knife, we can use that upper blade.
Right. This is our standard, I think, towel clip.
Standard towel clip, yes.
Towel clip, which can be used as a patella reduction forceps also, sir. I think. Wait some time.
Or holding the bone for its reshape. Like suppose we said, suppose we want to reshape the bone during the muscle pedicle bone grafting. So in that case, you have to hold the bone in a right manner so that we make a hole or make a reshape according to the shape of the core decompression. Similarly, this sort of instrument, what are the special use it can be used? Asked. Then again, its special use can be used during the patellar shaving, during the total knee replacements. We have to hold in the by both the side of the patella with the help of this towel clip.
Yes, sir.
While shaving the side of the patella. Yeah.
Yes, sir.
Yes, there is a number 4 and number 3 blade.
Yes.
Number 3 blade.
The Bart Parker.
Bart Parker knife. Yeah. This is Homan's retractor. Yes, it's a different types of Homan retractor.
Yes.
Why the slots are there? It is asked. Why slots are there? How much angle is there? It may be the 30-degree angle, it may be 60-degree, it may be 90-degree angle. The 90-degree angle may be there at the blade.
Yes, sir.
The slots are there because, slots are there to hold properly. Sometimes in the previous days, some weight is attached over there and it is hanged by the side of the table.
Exactly. Sir.
But nowadays it's not there. And so there is these are the purpose, I think.
Right.
Another, can you tell what is the special purpose? Special purpose of use this apart from the retraction of the soft tissue from the bone. There's some special purpose of using this. Special purpose I am telling. Suppose there is the PFN is being done for the unstable trochanteric fracture, where the proximal fragment is internally rotated and the distal fragment is externally rotated. So in that case, once we are doing this proximal femoral nailing in a closed manner, so what we'll do? Why introduce this sort of bone holding forceps through the proximal incision over the neck and give just make a forward press over this so that will bring the neck and the trochanter in the same line. So there is a special purpose. Okay, next.
So this is a
standard, it is a periosteum elevator. It is extremely. It is a Faraboop's type of periosteum elevator. So his author's name may be required. What are the parts? It is a blade. It is a thumb rest, and what is a handle? Handle is straight, and blade is also straight. It may be pistol shaped. There are different types of periosteum elevator, and there are some different modifications of the periosteum elevator also
which we can
be asked. And sometimes it is asked why the thumb rest is given. Name a operation where the periosteum elevator without thumb rest is used. That is for the mandible surgery. So these are the questions may be asked. Sometimes the blade may be sharp, it may be blunt, it may be straight, it may be bent. The different types of periosteum elevator. Why the periosteum elevation is required? Now, what is periosteum? Now, name a operation where the periosteum is basically used for. It is utilized for the specific purpose. These are the questions. So that is a femister grafting. It is used. Femister grafting where the periosteum is carefully elevated and the bone grafts are placed underneath the periosteum, and then sometimes the periosteum may be sutured over that. So there is basically that is femister's operation. Okay, next. Yes, this is the bone. This is a primitive type of bone lever.
Bone lever.
Primitive type, but there are some other modern varieties I already have shown. So basically, it is a handle. It is a blade. It is sharp, and the handle is fenestrated. Again, why it is fenestrated? In the previous days, some weight is tied over here. It is hanging, and that may save one as assistant. Now it is not used, and the blade may be sharp, may be blunt, it may be straight, it may be bent. Now there is basically general use is ABCO. Can anybody tell it's a special use? Special use of bone lever, that is removal of the bone, that is a femoral head during the hemiarthroplasty.
Right.
In that case, how many bone lever are used? That is the next question. There are two bone levers.
Two bone levers are used.
Yes, to remove the femoral head during the hemiarthroplasty operation.
Right. Now we have the Alice.
Yes, this is the Alice tissue. Alice and the Cocker's tissue forceps to hold the top tissues during the reconstruction.
Right.
Suppose there is some operation. So what are the operation? Like suppose it is a tendo Achilles.
Yes. Sir.
Elongation of tendo Achilles or tendo Achilles rupture, where it can be the ends of the tendons are held, and that can be easily sutured.
Yes.
Next.
And it comes in different sizes as well for the small tendons.
Different sizes.
Different sizes and that over there.
Yes. Next.
Yes, sir. I'm just. Yes, sir. So we have the Cockers, I think this is.
Cockers. What is the basic difference between Alice and the Cocker? Cocker is basically for the much tougher tissue because that will not slip because it has a teeth inside it. But the Alice is relatively finer tissues for the finer tissues, and the Cocker is for the much tougher tissues.
Right.
Basically, it is used. Okay. Next.
Yes.
I think it is a artery forceps. Maybe Spencer's Wells artery forceps. Right. Why it is Spencer's Wells? Because it is absolute the part that is it is a blade and the shaft and handle. It is 2:1.
Yes.
That is why it is a Spencer's Well artery forceps. But there is another variety. There is a mosquito.
Mosquito, which is this.
Mosquito is not maintaining this sort of proportion. Okay.
Right. So last but not the least, we have the forceps. There are different variety of forceps.
It may be non-tooth or tooth forceps.
Right.
Tooth or non-tooth forceps. Now some special use. What are the special use of these artery forceps or there is bone holding forceps? That is taking out the bone grafts. Special where the bone grafts are harvested from the iliac crest, and it is taking out this sort of tissues are usually used.
Right. So I think that should be the entire the coverage, I think, which will be like for the instruments, I think, which we covered over here. And sir, a special thanks to you for being there, because I think Dr. Bera sir could not connect to us because of some network issue and that. So, sir, any ending comments about the session and because we had
I am giving a extreme thanks to Abhishek and also Soham for their endeavor. This is, I think, they are the promising juniors. We are very much proud of you because you are taking the baton from us, and in the next future days you will become both of us, Soham and Abhishek. They make excellent program for our beloved students, because nobody is thinking of this sort of for the students, because all of we are running, and we have no time for our students. So I think I'm very much grateful, and I'm very much proud of Abhishek and also Soham for taking this sort of endeavor for our beloved students also.
Right.
And also I'm special thanks to all of our faculties, especially the Dr. Bera, who has a severe, very extremely busy. I think one has to learn from him. Even in a very extremely busy schedule, so he is doing a very important academic and administrative work. In spite of he is doing his job for the students. So this is extremely this is highly.
Sir was I called sir for the I called sir for sir the.
Yes, please, Dr. Bera, yes, please, because you are our encouragement. You are encouraging us extremely being with us. Please have some words.
Yes.
Sorry. Hello.
Yes, sir.
Yes.
Sorry, I was busy otherwise.
No,
we have been seeing you and we have been inspired, sir.
We are congratulating you because
actually, I had
several busy schedule. You are still with us.
Some schedule anyway. I know Dr. Pal will deliver the thing very nicely, and while he is there, academics will not be a problem. Yes. So more important to be faculty is not to. I know much more. Many of my juniors know much more than what I know, but the attitude I want to develop, that we at West Bengal are lagging behind in promoting teaching in a systematic manner, what I have seen across the India in other states. That if Soham and Abhishek as well as others have come forward, Dr. Pal is always most academic. So I think the WBOA with Rajeev Raman and the secretary will foster it tomorrow, and juniors will get a systematic learning. We should focus on not only passing examination, but rather develop an attitude so that we can lead, we can think beyond the curriculum, we can do some research work, we can engage our juniors, ourselves as juniors, motivate our juniors to do some pioneering things.
Right.
In what I think in the Western countries, they have their own problems and such issues which are different from Indians, and that is not addressed. That's why research was very much needed also. So academics is very much needed, and to promote it, I am always there. Okay, thank you very much.
Thank you, sir. Thank you, sir. So if you can give some input, sir, about regarding the instrument, we actually missed you in the instruments this thing presentation. Like okay. Me and Dr. Pal.
For the instrument, two things I always tell that we should know the simple instruments. There are two excellent videos by Professor NK Pal. There are elaborate things has been mentioned, but the attitude we know should develop that we should know each and every instrument, where to use and where not to use, what is the best use, number one. Number two, the general instrument we should be acquainted, because otherwise we orthopedic surgeons badly handle many a time soft tissues. That is not taken care of, and that gives rise to problem in the healing as well as the infection. Number three, we should be beware of Indian instruments because they have that not established protocol to use, and no systematic literature is also available. So we should be cautious about the newer instrumentations, so that while new companies implants we are using, we'll end up with so many problems. So these are the feedbacks, and we should develop some instruments while working. We feel very difficulties. Say Solapur sleeve was one discovered by Shiv Shankar, and that has given an advantage. I think while we fix many fractures, we need the difficulty and newer instruments needed. Thank you very much.
Thank you, sir. Thank you, sir, for the input. And so it was great that we could, we could use your presentation and your guidance for the program. Thank you, sir. Thank you so much. Over to AK Pal, sir. I think Dr. AK Pal, sir, can give a little bit.
Thank you. Just as a concluding remark, I think this is the just beginning. I think this, along with that, this sort of endeavor should be continued throughout the year, students. And I think under the leadership of Dr. Rajeev Raman, and there are several good youngsters are coming like you and also Abhishek, Soham. Not only that, there are some Shomodip, Arnab is there. Arnab is doing very extremely good for maintaining this sort of program, and also other students, other juniors also. So I'm very much happy to see you to take the baton from us. So not only
it's all your blessings and guidance, sir. Both me and Arnab, and I think Soham also, and I think everyone, we are indebted to you for supporting us in this program. I think Arnab can share a few words. I think the closing comments as
we will be always there. So apart from the practice, so please continue this sort of program throughout the year.
Absolutely.
Thank you.
Yes, sir. Yes, sir. Absolutely. I think it has been. We are getting so much good positive feedbacks from the PGTs personally. They are thanking me and everyone for arranging this type of programs, because this type of discussion is very important. All the doubt clearance and everything, and this type of different combination of this type of different faculties from regional and national. So this is a very unique platform. So it's very, very important and very, very good and advantageous for all of juniors. And many, many thanks to you, sir. You have been my teacher, my guide. We are grown up seeing you by your principles. So it's very nice, and we can't express that how joyous we feel to work alongside with you. So that's a great feeling. Yes, we'll do again and again. So I think this has been a tremendous program. So
you,
say good night to all of you.
Bye.
And stay safe. Again. We'll meet again. Thank you, sir. Good night.
Okay.
Meet you
again. Thank you, Arnab. Thank you.
Okay.
Okay.
Thank you. Bye.